Yeah.
Good evening, Madam Jayam Kannan, Madam. Good evening, Madam.
Good evening to one and all. Good evening.
Good evening,
Snehata.
Jay. Good evening, Mitra.
Hello, Snehata.
Yes.
Mitra, Madam.
Good evening.
Umayan. Hello.
வணக்கம் மேடம்
வணக்கம். வணக்கம் பலமுறை சொன்னேன் சபையினர் முன்னே.
வணக்கம் சபையினர். மேடம் அழகா பாடுவாங்க.
Good evening, Chandra ma'am.
பலமுறை சொன்னேன் சபையினர் முன்னே.
Very good, Chandra. Very good.
Anonmani, hi.
Hello, madam. Good evening.
Anonmani madam. Hello,
I could see Dr. Hemlata and Dr. Anita as well. So welcome. Good evening. I think once Dr. Pardeshi joins, we'll start.
Yes. Nirma is coming.
Good evening, Shas. Sir, good evening. That's good.
And we are live now.
Yes.
There you start the program.
Yeah. Just a moment. Sir, he said Dr. Pardeshi will just join in a moment. So once he joins, I think. Yeah, but then we can start, Bhavna, we can start the proceedings.
Good evening, respected faculties. Am I audible?
Yes.
Yes, ma'am. So I, Bhavna, on behalf of Corona Remedies, welcome you all for today's Core Connect webinar with AMOGS Medical Disorder Committee, along with Coimbatore, Krishnagiri, Vellore, Namakkal, and Aurangabad OG societies. Now, I request all the honorable dignitaries present in the webinar to proceed for the lighting of the lamps and start the session with a small prayer.
Bhavna, we can't see it.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
Now, I would like to begin the session and I would like to first introduce our convener, Dr. Umayal Murugesh. Dr. Umayal is a consultant at Sri Kumaran Specialty Hospital. Dr. Umayal is a Tambaran IMA president. She is a founding member of Tambaran OG Forum, member of World Association of Perinatal Medium, WAPM, and Safe Motherhood. Her interests are high-risk obstetric infertility and laparoscopy. Welcome, Dr. Umayal. Now,
thank you, Bhavana, for that wonderful introduction. I welcome each and everyone to this wonderful online CME. on difficult obstetrics, and we are going to discuss various situations where each of us could have been there when we are trying to have a delivery. And so this time we've got very interesting topics by great speakers. The first, Dr. Moses Seria will be joining us little late, and his topic is on can normal vaginal delivery be improved. And the second topic will be spoken by Dr. Mitra Saxena, and she's going to talk on the instrumental or the operative vaginal delivery. And we are going to have a wonderful panel going to be moderated by Dr. Sneha Vellore and Dr. Charmila Ayavu on difficult vaginal deliveries. And we have a galaxy of panelists from the various societies of Tamil Nadu. And so it gives me great pleasure in welcoming each and every one of you for this CME. And I would request Dr. Shobna Priya and Dr. Anit Kumar to take this event forward.
Hi, ma'am. Good evening.
Good evening.
Hi.
You can go next.
Now,
Good evening, Revati madam. Good evening, Sneha. Good evening.
Bhavna, you
yes,
can.
ma'am.
Yes.
Now, I would like to introduce our coordinator, Dr. Anit Kumar. Dr. Anit Kumar is a consultant at Sri Kumaran Specialty Hospital and Fertility Center. He is joint treasurer at Kanchipuram OBS and Gynae Society, South Zone coordinator of OXY, UNICEF, PCA, a past South Zone coordinator, and he is a member of Practical Obstetric Committee, FOGSI. He is a recipient of AICC RCOG 2022 Traveling Fellowship and ISAR Youth Icon in Fertility Award in ISAR Bhopal 2023. His interests are reproductive endocrinology and high-risk obstetrics. Dr. Shobna is a senior assistant professor at Chengalpattu Medical College and Hospital. She is joint secretary IMA Tambaran, member of Clinical Research Committee, FOGSI in 2022-23, Kanchipuram OG Society, and she has received Best Service Provider in PPI UCD insertion in Chengalpattu. She has also received Best Doctor Chengalpattu by District Collector recently. And her area of interest are high-risk obstetrics, gynec endoscopy, and gynec oncology. Welcome, ma'am.
Thank you. Good evening, madam. Good evening, esteemed faculties, dignitaries. We are now joined for this today's evening meeting. Education is not just about going to school and getting a degree, but it is about widening and spreading of our knowledge. Now we have gathered here to spread the knowledge among ourselves. I request Dr. Sneha Vellore ma'am to give the welcome address. Dr. Sneha Vellore ma'am is a chairperson of Breast Committee FOGSI 2019.
Thank you, Dr. Shobna. That should suffice. A very good evening to all the respected guests for today's program. My mentor, Dr. P.K. Shah, Revati Janaki Raman, Madam, and Madam Nirja Batla, who will be joining shortly. AMOGS office bearers, Dr. Rajendra Singh Pardesi, Madam Sujata Darvi, all the immediate past President, Dr. Nandita Palshitkar, Dr. Kiran Kotakoti, the President-elect of AMOGS, the ICOG office bearers, Dr. Lakshmi Shikhande, the chairperson, and Dr. Ashok Kumar, all the esteemed faculties, especially Dr. Noza Sheria and Dr. Mitra Saxena will be talking about the vaginal deliveries, of course, whether the rate can be improved, and Mitra will be speaking on the difficult vaginal deliveries, and myself and Charmila, we are going to moderate a very interesting panel, practical case-based discussions. So I welcome all the panelists, chairperson to this program, and without much ado, I would like to invite our chief guest for today's program. And for sir also, I don't think the introduction and reading the CV is necessary. Everyone knows him as past president of FOGSI and the past president of many organizations, a very highly respected person, I would say, who is helping or mentoring many like me. So we would like to listen to your precious words, sir. And over to you, Dr. P. Keshav.
Thank you, Sneha, for your kind words. Good evening, everyone. It's so nice to be a part of this Core Connect webinar arranged by AMOGS Medical Disorders Committee headed by Dr. Sneha Buyar. I'm happy to learn that there are many societies from Tamil Nadu and Aurangabad. They have joined this particular webinar. And it is a great pleasure to share this platform with somebody like Dr. Revati Janaki Raman, Dr. Nirja Batla, and Dr. Jayam Kanwe, who will be the guests of honor. And I thank office bearers of AMOGS, Dr. Rajendra Singh Pardesi and the rest, and ICOG office bearers, Dr. Lakshmi and Dr. Ashok Kumar. When I saw the topics which are going to be covered by Dr. Nozar Sheriar, Dr. Mitra Saxena, and Dr. Sneha and Charmila for panel discussion, I was very happy because these are the topics which are very close to my heart. Because the rate at which C-sections are going up in our country, I feel a day will come when we'll have to keep the workshops on how to deliver patient vaginally. So I think it is the right moment and the right time for all of us to come back to the normal thing, that is normal vaginal delivery. And it's always a great pleasure to listen to somebody like Dr. Nozar Sheriar. On any topic he talks on, and he is going to cover the very important topic, and that is, can normal vaginal delivery rate be improved? Very happy to see this particular title. And then Dr. Mitra Saxena is going to talk on operative vaginal delivery. Nowadays, the residents are afraid of using forceps, vacuum, and they are more comfortable with C-section, unfortunately. So I'm again very happy that she will cover this part, which is very important for the present day obstetrics and gynecological people that we have in our teaching institution, so they get some confidence. And lastly, difficult vaginal delivery, which is going to be covered as panel discussion by Dr. Sneha and Dr. Charmila. I'm waiting for that particular part of this session. I thank Dr. Sneha Buyar for inviting me to be a part of this webinar, and I wish her all the very best for all her future endeavors. Thank you very much, Sneha. And let us start with Mitra without wasting time. So I think it's going to be a long evening. Thank you.
Thank you, sir. Thank you so much. I now invite Madam Revati Janaki Raman for her words. Dr. Umayya, you can introduce Madam in short. I think Bhavna, no need to share. So Umayya will introduce. You can unmute yourself, Dr. Umayya.
Revati Janaki Raman, Madam, is currently the president of TNFOG, the chapter which was formed 2 years back, which is involving all the societies of Tamil Nadu, and she's doing a great job of uniting all the societies and trying to take things forward. And she has also been she's also the past vice president of FOXI, and she's an amazing surgeon and amazing obstetrical practitioner, and we are really very proud to have you here, Madam. And we would like you to give a few words on for the today's CME, Madam.
Thank you, Dr. Vellore, for your kind words. And it is indeed a great pleasure and a privilege for me to be part of this webinar on practical issues on labor. You know, when I was a director in IUG, I was surprised to see a big bell hanging in front at the entrance. And when I entered, the message was that long back when Dr. Krishna was the first director there, every cesarean, when it is done, the bell will ring so that all the PGs and students will rush to the theater to witness a cesarean section. To that extent, normal delivery was so common and cesarean was rare, and everyone was so eager to go to the theater to witness cesarean section. And now it was just rusted and it was hanging up. Now I thought that it will be ringing to witness a normal delivery in future. So it goes like that. So to that extent, normal delivery is becoming very, very rare. And the younger generation, they want to take up litigation as an issue to choose cesarean section. Why I should take a risk? So better go for a section, thinking that C-section is without any risk at all. So in that way, we have to educate our younger generation about the need and possibility of a normal delivery and how it should be done practically. But as Dr. Shah rightly said, learning in teaching institution has become a very, very rare opportunity today. So the teaching institutions should take up difficult deliveries, normal breech delivery. Vaginal breech delivery, I doubt very much how many PGs have seen that at all. Now, in our days, I myself have conducted 3.5 kg breech delivery for a primary, our own staff nurses, our own doctors in private setup also. I don't think nowadays people will take up the guts to conduct a vaginal breech delivery, and nobody is doing that also. Okay, so any type of vaginal delivery must be learned only in a teaching institution, and in the teaching institution, it is our duty to train our students. Now, the webinars like this also will help our viewers and also the practitioners to learn, though not practical, at least theoretically, how it should be approached. And I'm sure this panel discussion will give an idea about how to face the difficult deliveries and how to improve the vaginal delivery rate. I'm very eager to listen to Dr. Nausar Sheriar also about this, because decreasing the cesarean section rate, that is one part, but how to improve the vaginal delivery, that is very, very important, because vaginal delivery, many are afraid of, and many times, unless it comes out on its own. Okay, it should not go like that. And especially just like any case for an elective section is again increasing. That also must be looked into. And I'm sure this webinar is going to give a lot of insight on how to take up this vaginal delivery. And I'm also eager to listen to all. And I wish this webinar a grand success. And I wish Dr. Sneha a bright future and also success in a future election. Thank you very much.
Thank you, madam. Thank you for your wonderful insights into the topic. And thank you, Madam Jayam Kannan, for being present and blessing us all the time. I welcome Dr. Neerja Batla, who is the Professor and Head of Department of AMOGS Delhi, and who is also the former chair for FOXI as well as FIGO Oncology Committee. And Madam is the Vice President-elect for FOXI. And we are eager to listen to your precious words, Madam. Dr. Neerja Batla, over to you. You can stop sharing, Bhavna. Yeah.
Good evening, Dr. Sneha. Thank you for inviting me here. And I am so happy to be here to see so many illustrious personalities on this screen in front of us. And it is a pleasure to see Dr. Mitra, Dr. P.K. Shah, Dr. Revati, Dr. Jayam Kannan. So many people are here. It's so nice. I can also see Dr. Pardeshi and Dr. Sujata, Dr. Shobna. So good evening to you all, and for a very, very valid cause, because this is absolutely, I think, every word that Dr. Revati has said. This is a need of the hour to promote the vaginal delivery, even in teaching institutions like ours, which always had a higher cesarean section rate as we focus on the high risk. But now it has crossed the 50% mark and gone over to the other side. And it has really become difficult. And part of it is this problem of the placenta accreta spectrum, which we at AIIMS are witnessing an absolute epidemic. Every day or every other day, one woman is being referred from somewhere, which is a known person, somewhere unknown clinic. Last one has come. I said, private, don't say just private. Tell me which private, absolutely small unknown clinic. And we don't know what to do about it, because we cannot turn these women away. We have to keep them, and everybody knows about the constraints. that there are with these patients. So I think it's very, very important to look very closely at this group of first cesarean section, which is really the big problem. And, it has been so sad that recently we have even heard about our own students, our own OBGYN students who have encountered problems of the placenta creta spectrum. So I tell them all that you please take a pledge, you are not going for CDMR, because the patient is going to ask you, doctor, what did you choose? And if you are going to say, I chose cesarean, patient is going to say, these people who know everything, know what is better, have chosen cesarean. I don't need to think. I will choose cesarean. So I say at least a short trial is mandatory for everyone. Otherwise, you are giving the wrong message to patient. And in this era of so much of monitoring, so much of access to pain relief, so many things are there. I think we should not be so scared about it. Rather, we have to inculcate the patience amongst the obstetrician to be able to find a way and to make a system. So many years ago, when I first visited the US, I was very impressed to see the system they had developed of working in fours. They had a partnership of 4 people working in groups, and it was mandatory in New York to the obstetrician should be in the hospital when the patient is in labor by law. So every 4th day they spent in the hospital premises, and they adjusted amongst themselves. If I deliver your patient, you will give me X amount, and I will give you X amount and keep the rest, and you deliver your own patient, then that's it, and so on. So they had their economics worked out, and they had a work-life balance worked out. I think something like this is required for us, because we have to keep a balance of ethics and a balance of good science and a balance of good life for ourselves as well. I'm really looking forward to Dr. Nozer's lecture, and I will stop here now. Thank you so much.
Thank you so much, Madam Nirja Bhatla. And I too share with you that being an individual nursing home practitioner as high-risk obstetrician, I have been working for last 30 years, but it's definitely a changeover right from the tolerance of the patient and the forbearance of the obstetrician, and of course the interference by so many people. So definitely the practice has changed, and all of us are eager to listen to the speakers. So now I hand over the mic to Dr. Umayyad. I welcome AMOGS President Dr. Rajendra Singh Pardesi and Madam Sujata Dalvi once again, and over to you, Dr. Umayyad.
Now I would like to welcome the next.
Bhavna, you can display Sir CV.
I would like to welcome our next. So welcome Dr. Pardesi, sir. You have been the
It's okay. It's
I
okay.
think you, yeah, it's not readable, I think. You can stop sharing, Bhavna. I would just say.
Welcome,
Good evening,
Dr.
everybody.
Sujata Dalvi. Yeah, good evening, sir.
Good
And
evening,
Dr.
everybody.
Sujata. Yes.
Respected Dr. P.K. Shah, sir, Dr. Revati Janaki Raman, Dr. Nirja Bhatla, Dr. Jayam Kannan, Dr. Charmila, Dr. Sujata Dalvi, and Sneha Boyar. See, I congratulate Dr. Sneha Boyar and Dr. Omaya Murugesan for organizing such a nice, really interesting, because we are very much interested in this type of CMEs. Dr. P.K. Shah taught us for normal delivery. And as he told right, Dr. Revati told right, that even Dr. Mitra is taking over as operative deliveries, instrumental deliveries. So operation, we shouldn't, means we shouldn't neglect patient, we should do operative, but operator should be trained, as Dr. P.K. Shah told. And I told you, Dr. P.K. Shah used to stand by us only when we were doing forceps and vacuum deliveries. And this type teaching, I think is needed in teaching hospital only. But nowadays, instrumental deliveries will be very less numbers, because training is not there. So nowadays, now we received letter from government that the LSS rate has been increased to 39%, and what to do. I know there are many problems, but I think Dr. Nirja Bhatla in means capital, they can help us to relieve from Consumer Protection Act. It's quite a hassle for us, Consumer Protection Act. So for minor reasons also, after forceps, vacuums, and even eclampsia patients, and people are reaching to the consumer protections. And that's why people are fighting. Of course, some matters we feel bad. Some our people only they are telling, no. And we do 100% LSS for our BOH patient, high-risk patient, and our infertility conceived patient. This is also not true. We should give fair trials. I think Dr. Noza, Dr. Mitra, Dr. Charmila, and Dr. Sneha will be the right persons to demonstrate us and to educate us. And it's a really need of our. So I wish every success to Dr. Umayal Murugesan for her future endeavor in FOXI as chairperson, and to Dr. Sneha Bhoyar for her future endeavor in FOXI as vice president FOXI. I wish every success to this webinar. Thank you. Thank you so much for inviting me.
Thank you, sir, for your very warm words. We need to actually teach the art of vaginal deliveries to the youngsters in the coming years, because as we all know that now the government is looking into it, and as you told rightly, the legality of these problems should be taken into consideration, and some protection should be given for the doctors who are practicing normal deliveries. So only then people will go out and try to do normal deliveries. So even for a difficult vaginal delivery, even for a caput, or even for a minimal fetal distress, so much of questions are being asked. And so no wonder our younger generation are turning towards cesarean section to have a safe practice. So that was very well said by you, sir. And now I would like to call upon the speaker, Dr.
Madam Sujata Dalvi will just have few words from Madam. Madam is the Secretary of AMOGS and a senior consultant from Mumbai, and a very humble human being, very helping hand, I would say. So, Madam, we are eager to listen to your question.
Thank you so much.
Welcome, Sujata, Madam. Yes, Madam.
For a nice introduction. As a Secretary of AMOGS, I would like to welcome one and all for today's webinar. And today's webinar is on vaginal delivery, whether it is difficult, whether it is instrumental, or whether it is easy vaginal delivery. It is one of the very important part so far as an obstetrician is concerned. I would like to express my gratitude to AMOGS President, Dr. Rajendra Singh Pardesi, for always encouraging scientific sessions, something like this, which is on some part of an obstetric topic as such. I would also like to express my gratitude to AMOGS Medical Disorder Chairperson, Dr. Sneha Bhoyar, who has arranged this webinar along with few of the Tamil Nadu societies and Aurangabad OBGYN Society. And I would like to acknowledge the words of wisdom given by our guests of honor, Dr. Pikesha, Dr. Revati, and Dr. Nirja. And I would also like to express the efforts taken by our convener, Dr. Umayal Murugan, for arranging this today's webinar, and my best wishes to Dr. Sneha Bhoyar and Dr. Umayal for their future endeavor in FOXI, and best wishes for a very successful scientific sessions today. Thank you so much.
Without much wasting much time, rather, I would heartily thank all the respected, the illustrious people here who have been blessing us, guiding us all the time. And I thank all the president and secretaries of all the societies who are involved for today's program. And I hand over to the coordinators now, Dr. Anit and Dr. Shobna, for the academic session. We can have the second talk first. Bhavna, we can have Dr. Mitra's session first. Yeah.
Thank you, ma'am. I now request Umayal madam to introduce Dr. Mitra Saxena madam, who doesn't actually requires any introduction, to deliver a talk on operative vaginal delivery. Over to you, ma'am.
Mitra madam, welcome. And in a short notice, thank you so much for accepting to give a talk on the operative vaginal deliveries. Mitra madam actually needs no introduction. She's the Practical Obstetrics Committee chairperson of FOXI.
Umayal. Otherwise, the talk time will be finished. Okay.
And so we really love to hear you, madam. Over to you.
So I think just give me the sharing rights. And also I wanted to say that the screen I was not seeing fully. So you please look when I am projecting my screen, that can you see it fully or not? So 1 second.
Yes.
Yes, madam. We
Yes,
can
ma'am.
see.
Able to see your full screen?
Yes, ma'am.
Yes,
We are
ma'am,
able
we
to
can.
see your first.
So I just want to decrease my, that only I can very.
It's visible, Dr. Mitra, you can.
Okay,
start.
so I am visible and audible and my screen is visible.
Yeah,
I
perfect.
hope. So at the outset, friends, I want to make a small declaration and there is a disclaimer. So as an obstetrician, you're always stuck in some problem. And day before yesterday, I was stuck in another problem. So when Dr. Sneha gave me a call at 11 o'clock in the night, Dr. Mitra, will you do this talk? So I was stuck. I mean, like, how can I do in 24 hours? How will I get things ready to deal with some topic? And then after Dr. Nozer Sharia. So I was a little bit jittery, but I have to say this, that obstetrics is always a teamwork. So even presenting a talk can be a teamwork. So firstly, instead of writing operated word difficult, I took the liberty of converting my topic as art of instrumental delivery. So I have to thank all these wonderful teachers. They're really good teachers, Dr. Manjupuri, Dr. Sureka, Dr. Haresh Doshi sir. They have shared their videos, their things, they've discussed with me and liberally, open-hearted. So I really want to give them all the credit for whatever comes out of this talk. And I do hope that I can keep it very clinical, not theory, because this is not a theory lecture. Everybody who is here, all the respected seniors, Dr. P.K. Shah, Dr. Revati Janaki Ram, Dr. Jayam Madam, Dr. Neerja, Dr. Rajendra Singh, Dr. Sujata, every single person and the others, Umayal and all of you all are fantastic, obstetricians. So I've deleted all the theory part and I'm going to be sticking. Please switch off the mic. So I'm going to stick to maximum videos so that all those who are sitting there, the youngsters, and who have not even witnessed. So as Revati madam said that now there should be a bell that, okay, something is happening, so come and see. So I would like to invite all the youngsters to keep their screens open and look at it. So elective or emergency assisted delivery is with the help of these two wonderful instruments, the forceps and the vacuum. And you all know that over the last 2 decades, the incidence of this operative vaginal delivery has remarkably decreased in the West and also in our country, although UK is slightly better than USA, but it is really coming down. And these are all these graphs to show us that there is increasing rate of cesarean sections and decreasing rate of instrumental delivery. And of course, this image is quite alerting because the rising rates of cesarean section are alarming because now the government has started asking us questions. The media has started asking us questions. Well, as an obstetrician, we are in between the devil and the deep sea. If you don't do a cesarean, something happens. Why didn't you do it? If you've done it, you would have done it because of some economic reason. So anyhow, I think that as an obstetrician, still, as Dr. Neerja has already said her golden words, that we have to make a balance between ethics. So we all know that the instrumental deliveries are declining because of the fear of complications. So less use, less experience, more fear. And actually there comes a time when there is a stoppage of usage and more cesarean sections and the related complications. So in case anybody thinks that, okay, I'll be better off doing a cesarean section, this is just a compilation of the scar diasis, the horrifying adhesions, the cesarean section scar pregnancy, and the placenta accreta syndrome. So we all know now that the most important reason of rising cesarean, decreasing vaginal delivery, instrumental delivery is fear of litigations. And I'm happy to say that my source of talk today, the theoretical part is from the Green Top Guidelines, which has a revised focus on the safety aspects. So now, what is the crux? How do we overcome the fear of complications? So of course, the 3 most important things is that the patient has to be really correctly selected. The instrument has to be correct. And of course, the technique of the instrument used has to be, correct. I assume and presume that all obstetricians know all the prerequisites of full dilatation and bladder emptying and, inspection before and after the application. So I'm not going to go into those details because I want that we should spend maximum time sharing videos and talking about practical things. So now in my own learning, what I would like to share with everybody is that the most important reasons for a successful vaginal birth is that all the P's are to be in alignment, which means that the passage, the pelvis, the soft tissue and the bony pelvis all has to be very well assessed when any woman is in labor. Then the passenger, the position, the side of the back, the head, the attitude, all these things which we learned in our undergraduate days and in our postgraduate days, they still hold true, even when we are dealing with a woman in labor, because if we are not aware and we just come at the last minute and don't make the proper examination, we are going to be stuck. So importance of knowing the attitude and the size and station, everything of the passenger. Now coming to power, we all know without power, there is no way moving forward. And most important is the parturient who has to push well. So we all have to remember the descent, the rotation and expulsion after the cervix is fully dilated is because of the voluntary pushes by the pregnant lady. So what I want to tell everybody and just, always keep it in mind that our instruments are actually only doing this part for us. The rest, the passage, the passenger and the power is all fixed actually. If the contractions are not adequate, then we are well within our right to use Pitocin safely if there's not going to be any acute fetal distress. So these three factors, if they are fine, then the instrument is only replacing the parturent's voluntary pushing. If we keep this in mind, and also we know what is the level of the present leading bony part, then we'll be able to do whatever, vaginal delivery within instrument very artfully. That's why I put the name Art of Vaginal Delivery. Now, coming to selecting the right patient. So the first thing is that, we have to remember that if we are in good second stage, there would be contraction every 3 minutes. And in 10 minutes, there would be 3 contractions. So the rule of 3 means 3 pulls at the instrument, whatever you're using, and without any panicking. So actually, in effect, if everything is fine, and if you are confident, the obstetrician is confident, then the vaginal delivery can be accomplished in less than 10 minutes, which is actually on a time scale, it is much less than actually doing a section, unless of course you are doing the trial in the OT. So we all know that those are the conditions where the trial of instrumental delivery will be done itself in cesarean. Otherwise, when you are in the labor room, it's pretty quick thing. So now, whenever there is fetal distress and you know that the baby needs to be brought out very quickly and can be brought out, there are conditions like RHD where, lift out with outlet forces or a vacuum is in place. And of course, now with increased use of epidural and the patient's pushing is not there. So that is why we have to artfully bring out the baby. Now, we have to keep these contraindications in mind. And I would like to just reiterate that it is that the use of vacuum has to be abolished at preterm babies, because we all know that's going to cause a lot of subgaleal hemorrhage and more complications. So the level of evidence is in the right, and I'm not going to, go into so many details. Now, most important thing is careful clinical examination to have successful delivery, which means per abdomen that both the poles are and the per vaginal examination, very, very important that we know that there is no caput, head is deeply engaged, and where is the occiput, where is the sagittal suture. So all these basics have to be very, very clear. And as a safety procedure, there's now use of ultrasound to see the angle of progression, especially when you are using instrumental delivery. If you have an ultrasound in the labor room, that is of utmost significance, and that can actually help us choose the instrument If that is angle of progression is good, and we know that the capacity is good, the position is fine, and there is no distress, we will be successful at conducting the instrumental delivery. Now, these prerequisites are until here, whatever may be the instrument, whether it's the faucet or the vacuum, these are the conditions that have to be met. Now, proper selection of the instrument. What is the most important thing is, what are you comfortable with? So if you are you have seen a lot of forceps, you know that it is not a big deal. And if you have been doing vacuum, and elastic cup is a very safe and a good instrument, you can choose your instrument depending upon your own proficiency. Personally, we used to do outlet faucets, low mid cavity, but being in practice, now I have resorted to vacuum extractors. And even though, vacuum has higher failure rate and forceps are more likely to, accomplish the vaginal birth, but there is more likely to be perineal trauma as per our evidence. Now let's come to the right technique. And we all know, I'm going to go with the vacuum first. So cutting out all the details, the most important key points is that the vacuum cup should be put as posterior as possible and midline, so that when you bring it out, it maintains the attitude of flexion, or it could be paramedian. If it is at the flexion point, again, it will be, coming out very easily. But if our cup is placed somewhere in the middle, whether it is median or paramedium, it is going to cause deflection of the head, and it is going to cause some problem. There can be popping off and all the problems. So now let us look. This is a very simplified diagram. I would like to actually spend more time so that you all can see the videos which have been shared by really good teachers. So what is very important is that atraumatically it has to be put, and no soft tissue should come in between. Until please. Now, the reasons of failure is improper placement of the cup, incorrect application of traction to the fetal head, and if there is large caput, I would say that would be a wrong choice to use a vacuum when there is caput. And if sometimes it's failure because of the suction equipment and also in operator. I have to thank the LHMC staff for sharing this. I would request the host to please switch off the mics of others. It's disturbing me. So this is a beautiful video, which I think everybody deserves to see till the end. I will fast forward it. There's not a big deal in applying the vacuum. We are all proficient, lubricated, after having ascertained the station of the head, and try to put it as close to the occiput as possible. And most important thing is how you're going to be pulling the vacuum cup. That is most important, because most of the pop-ups happen when you are trying to put the traction. So you have to keep your traction at right angles to the cup and just go with the contractions. If the contractions are inadequate, you have to supplement it with oxytocin drip. Okay, so I'll just let you see, because it's so beautiful that you'll see how nicely the cup has been placed, and the operator is not in any hurry. The problem is that putting the instrument, one is in a hurry, extracting, one is in hurry, pulling out the baby, the operator is in a hurry. So see if this obstetrician can do it. I think each one of us can, try and do our vacuums like this. It has to be slow, gentle, and without any hurry, no panic. And once the baby is out, we'll be able to see where the cup was actually placed. That is why I would like you all to look at the video completely and see how beautifully, without episiotomy, this vaginal delivery has been accomplished. So till the chin is delivered, and see how posteriorly the vacuum was applied, the cup. And so that is why minimum diameters came out. There was no extension, no tears. So that's, I think, wonderful by Dr. Nishtha from Lady Harding. Thank you so much. Thank you, Dr. Manju, to share this video with me. So now this Dr. Doshi is also, Harish Doshi sir has also, shared his video. And again, I'm not going to talk about the types of the cup, but I would really say that we should all look at the procedure, and especially we have to look at the way the traction is applied. That is the $1 million question, that you have to ensure that the contractions are good. And remember, we don't have to have every minute a contraction, but the episiotomy has already been given. And the beauty about vacuum cup is that it also causes rotation. If we keep gentle traction, steady gentle traction, and then we will also see that how the vacuum cup achieves the rotation. We can see the rotation happening when it is descending. So remember, friends, that whenever we are using any instrumental delivery, we are accomplishing the process of rotation, if it is not completely rotated, as by use of vacuum, and the descent and expulsion. So forceps, oblique vacuum, they are going to only achieve these things. Again, you have a look where the cup was placed, how posterior it was placed. So that I wanted to show you. Now, when to discontinue vacuum, we have to again remember, if there is no progressive descent with moderate traction during each pull of a correctly applied instrument by an experienced operator, it's time to call it a day. And what is the maximum that is allowed? And that is maximum of 3 pulls to bring the head to the perineum. And you're not allowed multiple pop-offs. So maximum 2 pop-offs. This is, as per the revised guidelines, that these are the things that should be followed. And of course, if you are in a panic, you're going to have a pop-off. If you're in a panic, you would be pulling without the contraction. So this is what experience teaches us. And that is why I showed these videos, that how, steadily you have to take out the baby. Now, coming to application of forceps. So again, here, I'm not going to be talking about the description of the forceps. I would like to spend precious time on sharing these beautiful videos. So this is a video by Dr. Sharda and Dr. Muntaha from Lady Hardinge Medical College, contributed by Dr. Manjupuri. So see, in forceps, it's, the episiotomy has already been given. And what we have to remember is that as per the guidelines, the episiotomy should be at 60 degrees. So we all know that the forceps, if it's an outlet forceps or low mid cavity, it has to be reconstructed at the front of the perineum with the identifying the left and the right blade. And first we have to, of course, the per-abdomen, the per-vaginal examination, and ascertaining if the rotation is complete or maximally at least only 45 degrees. Till then it is allowed, but ideally it should be in AP diameter, the sagittal suture. So now here, after lubricating the left blade, you push it in, and the trick is, if the blade goes in nicely, then the stem or the handle is going to stay on its own at the perineum, and then introducing the other blade. So it's a direct application. And now when the head is already at the perineum, then all we have to do is gently extract with contraction. Again, after there are uterine contractions, you have to pull at the head and bring it out gently. So you have to see that this is not a hurried application, hurried extraction. How, the efforts of the mother will automatically augment our expulsion, because once she knows that we are aiding her, from where the woman gets that last push. But yes, I have noticed that it is always there. So after, this is an outline application. And these are some wonderful videos by Dr. Doshi sir. So again, the first video is of outlet forceps. And I just want that everybody should see the time that they take to pull it out is most important. If you hurry at that time, if you hurry at the time of, insertion, that's the time that you're going to injure the soft tissue. So you have to be very gentle in putting the forceps. And then at, even if the blades, suppose there is no contraction, you let the, blades handles be apart. It's not going to cause any damage. And when the contractions come, that's the time we lock the blades and then we apply the traction. That's why I'm not, fast forwarding it, because when the contraction will come, then sir is going to lock it and then pull it out. So the curve of Caris has always to be, remembered. So when it's an outlet, all you have to do is bring it down and upward and forward so that the head will be delivered. See, it's always a gentle extraction. And then, of course, the important thing that you have to check for any injury to the face or injury to the soft tissue. Now, this is a low mid-cavity forceps. So the station is higher. In forceps, it's always better to have, in this patient, this is under spinal anesthesia, as sir told me. So episiotomy has already been given. In low mid-cavity forceps, even there, head should be +2. So the rotation should be nearly complete. And here the trick is that if, the forceps are not locking, as you see that they are not. So the trick is either to push the left blade up or to make the right blade, assist the right blade in going up and rotating it, and then ensuring that it locks. So see here, it's not locking, but then we'll see that the things are that push the blade higher up, and on the right blade, attempt it to rotate and go up. So we'll see that this is a successful vaginal delivery after low mid-cavity forceps. So this is the trick. Let's see how he has twisted the right blade, push the left blade up, or twist the right blade and make sure that the blades lock, and then wait for the contraction and then extraction. In low mid-cavity, the station is a bit higher. So we have to bring it down first, then forwards, and then upwards towards the abdomen. So with good contraction and a little bit of rocking movement is allowed. And of course, I would like to take the inputs of our seniors that whether they would advise pudendal block. Personally, for outlet, we have never used pudendal, only local infiltration. But for low mid-cavity forceps, when I used to apply, we used to apply pudendal block also, because it actually makes it, the soft tissue relaxes actually. So coming to, this is, I would really like you all to share this, watch the Keelan forceps. So we all know that the Keelan is a forceps which doesn't have the lock. And, when we were postgraduates, were so proficient in telling all the ways, but here also, it looks so simple. So the trick was that the occiput was on the right side and it was a ROT. So the left blade there is a direct application. And actually, when you see Dr. Doshi doing it, it doesn't look difficult. And sir shared with me that he has done numerous, almost 30 Keelans. But of course, for the last few years, he's not doing it. But good, we have a teaching video to show what Keelan forceps is. So the left blade is put anteriorly, direct application. And now I would like you all to appreciate that the right blade will be introduced posteriorly. Again, in this patient, it was under spinal anesthesia, as we discussed before I'm putting it after discussing with him. So this case he has done after spinal anesthesia. So see how nicely, the beauty of Keelan is that there is no lock. So any asyncretism can be automatically corrected. And now see how nicely he is going to rotate it from right side to make it, make the occiput come anterior. And the rotation has to be done when there are no contractions, and the extraction has to be done when there are, uterine contractions. So in between contractions, the rotation is achieved. See, now he is almost finished with the rotation. And now we'll appreciate that how nicely it's going to be extracting the head of the baby. Just wait for a few seconds and it will be done. Actually, I am fast forwarding it, but the videos are unedited. You can actually appreciate that the time of artful vaginal instrumental delivery is not so much. See how beautifully it has been done. So now this is one low mid cavity forceps for phase 2 pubes. Do I have time, Dr. Sneha, or I can go ahead with mid cavity forceps for after coming?
Yes, ma'am. You can please show us those videos, madam.
Okay. I know that is why I kept theoretical.
I think that should be the one. Brief.
So this is a beautiful.
After
Again,
that
this
you
is,
can conclude.
see, the problem is that in phase 2 pubes, we often make a mistake in diagnosing it. So whenever there is delay in second stage and patient is getting exhausted trying to push out, sometimes even in the best of hands, this, where is the occiput could be missed. But herein, if you have applied forceps and you've, delivered, ideally one should have diagnosed that this is, occiput is direct posterior, so that you know exactly. So you have to bring it down till the bregma is there, and then you have to pull it forwards and upwards so that you can deliver the rest of the head.
Yeah.
See, you can actually see how beautifully the head has come out, and the delivery is accomplished. Now I would like to share the last
4 minutes, I think. Yeah.
No, I am going to be finishing in another 5-10 minutes, 5 minutes or so. So this is an after coming head of breech. So I also, when I was a registrar, I had the opportunity to deliver a multi with 3.5 kg breech, and I was stuck by myself. So what I did was remembered my boss's, direction that in after coming head of breech, the best thing is to apply mid cavity forceps. That's exactly what I did, and I'm happy to say that if anybody has this, experience, they will, share it, that it is very easy. So, of course, I apologize that, in normal circumstances, we're supposed to cover the baby with a toilet, with a towel, and even enclose both the arms and bring it up. So, and then it's a direct application, ascertaining where is the chin, and there is, when I applied, I did the same. I first put the left blade and then put the right blade. But yes, actually, it's okay. Yeah, he has also put the. Okay, now he's putting the right blade and he has put the left blade already. And then we are supposed to take the whole baby up with a towel along with the arms like a hammock, and then extract the head of the baby. And actually, this prevents sudden, extension and tearing of the tentorial tear. So now when should one discontinue forceps application? So if the handles do not approximate easily, despite all your tricks, that is pushing the blade up, using one of the blades to rotate the, head and lock it, then it means there is something which you have missed. It will be better to abandon it, because you don't want to actually crush the head. You know that you have to take it out, safely, and discontinue the rotational forceps if it's not easily achieved with gentle pressure. Now, again, if within 3 pulls you're not able to make any descent, you have to abandon the procedure. And apart from outlet forceps, the low mid cavity and the instrument rotational would be better off in the operation theater. So now it is extremely important that all these procedures, there should be a consent. Now, in our antenatal period, it is, actually prudent to start telling them when they ask us, Doctor, sab kuch theek ho jayega, then you say, yeah, if you take good pains, you push down, everything is fine. But in case there is any problem, we may need to assist the vaginal birth, or we may have to do cesarean section at the last minute also. So all these things, if we tell them in antenatal period, it will not come as a shock to them. And actually, we don't need to take a written consent. If we have spoken to the patient and the relatives in the antenatal period, and at the time of birth, birthing, if we have to do these instrumental deliveries, then we can actually just give a verbal information and take the consent later. Now, what is important is that whenever we are thinking about rotational delivery, especially with the forceps, most important thing is, of course, the skill of the operator. But for a trial of assisted vaginal birth in the operation theater, a written consent has to be taken. This should be taken. Now, where exactly should we perform this instrumental delivery? Outlet forceps in the labor room, anything beyond that, because the station is higher, the rotation may not be complete, and there is a chances that there could be a failure. So one can consider trial, and trial of forceps should be done in the operation theater, taking the consent. So in non-rotational low pelvic lift out vaginal births, of course, it's okay to do it in labor room. So especially like in heart disease cases, or just, patient has been in second stage and she's unable to push out. So instead of now giving severe fundal pressure, use the outlet forceps.
Yeah, I think.
So what a very important thing is, now this episiotomy, as you would have seen, if it is lax tissue, no need to give episiotomy for vacuum or even for outlet forceps. But in primies, it is seen that if an episiotomy is given, that decreases the incidence of OAC, especially in the nulliparous, especially if we are doing forceps. And whenever we give an episiotomy, this should be at the 60-degree angle. Antibiotic prophylaxis, yes, prophylactic antibiotic is order of the day whenever we have maintained full hygienic and aseptic technique. How to prevent litigations? As I said, that documentation, speaking in the antenatal period, then of course being proficient, taking right decisions at the right situations, and documenting whatever you have done. In case there has been any problem, for example, if there is a cervical tear, there is a vaginal tear, there is major obstetric hemorrhage, or there's a complete perineal tear, and we know that after instrumental deliveries, there will be shoulder dystocia and other things. So it's better to actually complete all your notes and, of course, speak to the patient and the relatives about what has happened. If you document that there is a tear, then of course we will be safe, because instrumental delivery, you know that there can be tear. But if you don't document, you're into trouble. So the way forward is good operator training, choosing the correct instrument, good documentation, and good antenatal counseling. And actually simulators are in big way to help, get back the confidence or teach to the younger crowd. And of course, initial few, deliveries have to be done under expert supervision. These are the pictures of the simulators. And of course, everybody has the second stage cesarean section at their disposal. But I would still say, even if you have to do second stage cesarean section, then you have to be very judicious in the timing of your decision. You cannot actually wait till the head comes right at the perineum and then you develop cold feet. Friends, it will be good to pick up your release forceps. And just
Thank you so much, Dr. Mitra.
So, just one second, Suneha. So at the end, it's all about training, assessments, standard operating procedures to be followed, and all the prerequisites, all the indications, contraindications. Your equipment should not fail. Your vacuum should not give up at the last minute. And this only requires skill, training, and confidence building. So the take-home messages are that we have to not forget that the instrumental delivery has a very important place in modern obstetrics if we are wanting to reduce the rate of cesarean section in the primary gravida. It's an art. It's not that it's a difficult It should not be a difficult instrumental delivery. It has to be an artful instrumental or a vaginal, assisted vaginal delivery, so that we are able to bring the mother and a healthy baby. Informed consent, all these tools should be available for all the obstetricians. And it has a very, very important role. Giving up on these things is kind of cutting your own hand at being efficient as an obstetrician. Yes, I know the times are not good, but we can always share skills. I'm really grateful to my teachers, friends, Dr. Manju and Dr. Haresh, to share. And thank you for allowing me to show these beautiful videos. Thank you, Dr. Sneha, for challenging me to present a talk.
Thank you, Mitra Madam, for that amazing talk. And those videos were really of a very level quality. And actually, like as you are rightly saying, Madam, we have to promote even breech delivery. That's what they are now saying. Like, it's not that the breech should be actually delivered by cesarean. There is always an option of vaginal delivery, and we have to promote that the primary breech is no more C-section. So we need to conduct live sessions, and we need to take this to our consultants so that we should start practicing all these things in a very nice way so that we can all promote vaginal deliveries. Thank you for that very wonderful talk. And I think we can go to the panel next.
Sir,
Thank
Dr.
you.
PK Shah, I would like your comments also, sir.
Sir, we cannot hear you,
Sir,
sir.
please unmute yourself.
Okay, you covered the topic so beautifully, especially vacuum and forceps, and the videos were fabulous. So I think this will give some sort of a stimulus to the younger generation to go ahead and do instrumental vaginal delivery. I think as a unit head at KEM Hospital and Sion Hospital, we used to have about 5 to 8% operative vaginal delivery rate right from 1984 till 2016. It was between 5 to 8%. And people used to learn. What has happened today is that the person who is heading the unit, he or she is not confident enough to do any operative vaginal delivery. So if the younger generation, the associate professor, the assistant professor, the registrar, house surgeon, if they are not seeing instrumental vaginal delivery, I doubt whether they will do it in their private practice. So I think there is a need to revive instrumental vaginal delivery. It is something fabulous. If you really ask.
హిమ్ము ఫోన్ చేసింది హిమ్మక్క సార్ మాట్లాడతావా
Please mute yourself.
So I think we should promote instrumental vaginal delivery. The only way you can do is to demonstrate in the teaching hospitals live to the residents and the juniors. I hope it happens. Thank you very much, Mitra. It was a superb talk. And
Yes,
I
thank
enjoyed
you.
each and every second of it.
Sir, actually, that is why I cut out all the details about the instrumentation. I said, let's just share and look at the techniques.
In fact, that's the reason we have listened to the videos and we have watched the videos by Dr. Harish Doshi and Dr. Taide and few more. So I requested Dr.
Manjupuri,
Mitra,
Dr.
yes,
Manjupuri.
Dr. Manjupuri. In fact,
Yeah.
these were all three are, options for speakers I was waiting for. And that's the very reason we contacted with you late night, Mitra, and you did wonders. Thank you so much.
Thank you, madam. Now we will step on to the panel of difficult vaginal deliveries. I would like to welcome Dr. Sneha Buer ma'am and Charmila ma'am for the panel discussion on difficult vaginal deliveries. Charmila ma'am, our Vice President elect, Chairperson Clinical Research Committee 2016 to 2018, National Coordinator for UNICEF Foxy PCA and MEDA Foxy PG program, ISAR Gurukul 2022, and further on, and Dr. Sneha Buyar ma'am is medical AMOGS chairperson of medical disorder and Foxy breast committee chairperson 2019 to 2021, and over many more awards. Over to you, ma'am.
Yeah, I think Charmila has some emergency, so Charmila will do her bit first, and then I think I will be taking over.
I now welcome all the panelists. Madam. Charmila ma'am.
Shobna, you can introduce them, please.
Yes, ma'am. Dr. Manon Mani ma'am, who is a president, Coimbatore Society. She is now in Coimbatore Medical College, HOD, professor and HOD. Next, please. Dr. Chandra Ponusamy ma'am. She is president, Namakkal Society, founder president, and member of TNFOG. And she has many awards to honor credits, Best Doctor Award, Best Women Achiever Award. Dr. Rekha Rajesh ma'am, who is the president, Osur Society. And Anita Tamare Selvi ma'am, secretary for OG, and Dr. Swati Rathore ma'am, secretary of Vellore OG Society, Professor CMC Vellore.
Dr. Muruga Lakshmi is there. She's a professor
sorry,
at
ma'am.
Coimbatore. Yeah, she's a professor
Sorry,
at
ma'am.
Coimbatore Medical College.
Secretary of Coimbatore OG Society, and Dr. Aparna Raul ma'am from Aurangabad Society.
So how many have joined, Dr. Shobna?
Madam Rekha ma'am, 3, 4, 5 are there, ma'am.
Anita, I'm seeing.
Chandra ma'am is there, madam.
Yeah, madam is there. Actually, from Aurangabad, who has joined from Aurangabad?
Raul, Aparna Raul.
Yes.
Can you name yourself, please?
Yeah, I can do
Coming
that.
as Zoom user.
Dr. Aparna Raul, who is the president of Aurangabad Society.
Welcome, madam. Please rename yourself. Mine is a little, because Dr. Mitra madam has covered so much on instrumental delivery. Mine is actually on difficult vaginal delivery. Sometimes, like whether it's worthwhile waiting on a case and then going for an instrumental delivery, because sometimes it can be good and sometimes you can land up with problems also. So thank you, Sneha, for the opportunity. We'd like to wish you the best for all your endeavors, and to Dr. Umayal also. So this patient is a 22-year-old primee. She came on 6th of November. That was almost like a term pregnancy. This lady came. She came with history of leaking for half an hour, pain abdomen for one and a half hours of leaking, pain abdomen for half an hour. She's had regular cycles, married since 1 year, first conception, no medical problems, no metabolic problems, nothing of that sort. Examination vitals, NAD, uterus term. Contractions were 2 in 10 minutes, lasting for 40 seconds. She had clear fluid leaking. PV examination revealed that cervix was 75% effaced and 2 fingers loose. So we gave her antibiotics because of the leaking. Enema was given. We give enema as in a center still. FHS monitoring was done every 15 minutes. She came around 6:30 a.m. in the morning. And at 8:30, the contractions had not improved. It was like 2 contractions in 10 minutes, 35 to 40 seconds. She was shifted to labor room and augmentation with oxytocin was done. It was done with continuous fetal monitoring. 10:30 a.m., the contractions were same. Actually, they were good enough now, 40 to 45 seconds now. At 12 p.m., the cervix was 6 centimeters dilated, membranes absent, and vertex had come down to 0 station. 1:30, she started pushing, so we did a PV again, and this time it was 8 centimeters dilated, membranes absent, vertex at 0 station, caput was there, and there was little bleeding. 3:30, uterine contractions maintained, FHS regular, cervix was 9 centimeters dilated, absent membranes, vertex at +1, but still a thick anterior lip of cervix seen, caput was there. 4:30, cervix fully dilated, membranes absent, vertex at +1, caput plus, FHS regular. But as it seemed to be a very slow progress of labor, the advice was given for cesarean section. But the relatives said, as the FH was quite fine, they wanted to wait for some more time. She became fully dilated. But because of suboptimal maternal pushing efforts and there was late decelerations. A decision was outlet forceps was taken at 5:20. Bladder was catheterized. And the findings were contractions well maintained, PV cervix fully dilated, absent membranes, vertex at +2, occiput at 12 o'clock, outlet forceps applied. A female child was delivered at 5:25, 3 kg baby. Apgar was 4/10. Resuscitation by the pediatrician was done. After 10 minutes, the baby had a apneic spell, so the pediatrician intubated the baby and ventilated it. Baby was shifted to an ICU. Mother was examined under anesthesia by the time, and she had bilateral lateral phonic tears, which is sutured, and complete hemostasis was obtained. The baby had a very torrid course in an ICU, developed convulsions, and died on 8th of November, 2 days after the delivery. So I'd like to ask the panelists, like, what went wrong? Can I ask Anita first? Anita?
Yes, madam.
Yeah. What do you think could have been done better?
There was a slow progress of labor. Partogram was plotted, ma'am.
Partogram showed a very slow progress. Do you
Yes,
want me to go back again and tell you?
No,
How it progressed? It was a very slow progress.
So I think the early decision should have been taken for.
No, that's what I wanted to know. Like, how long will you wait with what dilatation?
Time is there is a dilatation of 1.5 centimeter per hour with good uterine contractions of.
So suppose it's not 1.5 centimeters per hour, what will you do?
Already
we have to.
Yeah. Swati wants to say. No, Swati, yes. No, Dr. Aparna is right. See, it is a slow progress. She is expecting 1.5 centimeters per hour.
Yeah.
Contractions are very good. What are you going to do?
Just PV to be done. PV is done properly. There is no problem. Only the caput is there. We have to tell the patient not to push because caput is formed from the 8 centimeter because
How many of your patients listen to you when you say do not push?
Yeah, that is there. Either give antinomial something so that they will push little slow. Like we don't need the pushing early. It's because the premature pushing only she had all the problems.
Okay.
That
Anita,
is one thing.
Yeah,
Second
yeah. Yes, sir. Yes, ma'am.
I thought it can be because the two things are there as out. First thing is bilateral vaginal tear, and second thing, the baby went to the ICU.
Yes.
So somewhere the application it will be proper, but there is some fault is there. What I can see, like it may be the difficult delivery.
No, I'm not talking about the maternal. No, maternal factor. I'm not talking about the baby. Mother had the suturing was done and she became totally fine. But the baby we lost. So what could have been done for the labor?
In the partogram, we also need to monitor the baby status also, madam. We should
baby status was totally fine till delivery. The deceleration, once the deceleration started, forceps was applied and the baby was delivered in the next 5 minutes.
Same early intervention for termination by.
So, what time should the cesarean should have been done then, Dr. Aparna? Meaning intervention in the form of cesarean.
Good evening, Chamila. Hello.
Hi. Yes, Manon Mani.
Yeah, Mano. Yeah.
Mano. Yeah, so, Mano, please say.
Actually, as per the recent guidelines, as you have been 26 centimeter, the active labor starts and observing everything seems to be okay. With the 3+ caput, was there any caput 3+, whether it could be because of the patient pushing or if there is any mild CPD miss there?
See,
which would have caused the,
now it has come to a status we cannot say anything to the patient. Respectful maternity care has become like disrespectful obstetrician care. That's what it has turned into. So you tell her not to push, she will push. If you tell her not to move about, she's going to move about. She's going to say, I saw Google and this I can assume whatever position. This is all we are hearing now. Practically, see, this patient was totally monitored. The baby had good heart rate till the time the deceleration started and she was delivered in the next 5 minutes. That tear was expected because that baby was there for the long time in the vagina. it was not a delivery which was according to what we expect. It was quite slow. So that
Yes,
tear I
yes.
accept. But why did this baby, in spite of monitoring, and when you say that the American guidelines say wait for up to 6
3 hours.
centimeters, and after 6 centimeters, you wait for almost 9 hours till you go into 8 centimeters. Is it worthwhile? That's what I'm asking from our scenario.
They say with full dilatation without epidural. I don't think it's possible. For guidelines, they wait. That's what we have to have.
You are a person who's managing so many deliveries in your college, so you must be getting the feedback from your assistants and all. So what do you think is feasible for India? Should we wait for such a long time in our patients? That's what
I
I'm
think
asking.
Dr. Charmila, Dr.
Yeah.
Hema is writing whether she can contribute some points.
Dr. Hema is from which place?
Yes, madam. I am Dr. Hemlata from Madurai. Actually, I came
Yes,
for
miss.
chairing Dr. Nazar.
Okay.
Madam,
Yeah,
here,
please say.
I just want to add some point that the patient has come with membrane structure. She is being leaking for more than 8 hours. So she has
1.5 hours of leaking.
No. The process after you came for delivery.
Delivery was that is there. Yeah.
So first you have to inform the patient attendants we can wait only to 6 to 7 hours. If more than that time it has the baby will
See, so what is there a guideline which says that you cannot wait
wait
with
a
the
minute,
leaking?
madam. The patient, since she was leaking, she would have gone for dry labor. Whereas in Western countries, the fetal blood gas analysis and more can be analyzed. Whereas just by monitoring the fetal heart rate will not go for
This was not a prolonged second stage at all.
I don't
second
mean
stage
the
was
second
quite
stage
okay.
alone, but the dry labor has been.
No. Will you do an ABG for the baby just because it's a prolonged first stage? That's what you mean to say?
No, as long as CT is
No.
okay, it is.
I can add one point that we can go for a scan intranatally that the liquor has been completely drained or not. If the liquor has been completely drained and though the fetal heart rate is being good, we can't say that the baby will be good enough till the point of delivery.
No, that's what I'm asking. When would you have intervened and did what?
I would have intervened by around 12:30, madam.
And did a cesarean?
Yeah.
Yes, perfect. That's what I wanted. Others who are all against and who are all accepting? Swati, I talked to. Any other panelists has joined? Dr. Aparna has already given her opinion. Manon Mani has given her opinion. Anybody else is there? Umayal? Anybody else has joined?
Dr. Chandra ma'am.
Chandra ma'am? Madam is a senior obstetrician. Madam, your opinion on this? Chandra madam?
The thing is, if you are following the guidelines, looking at the CTG, it is normal, then it seems everything is perfect. We can wait. But then the result in our hand, that is very horrid. So what to be done? This is how we continue.
This is what we are facing every day. That's what I'm saying. See, I will tell you the guidelines of what the American guidelines, which has changed. The consortium on safe labor, which came out in 2010, started the trend of changing the dystocia criteria. 62,415 parturients were considered in this consortium statement. The average labor curve was constructed by parity. Estimated duration of labor was stratified by cervical dilatation at admission, and every centimeter by centimeter they stratified that. And they said 4 centimeters dilatation to 5 centimeter dilatation, you can take 6 hours. And from 5 to 6, you can take 3 hours. Active phase starts only at 6 centimeter according to his guideline, and up to 6 centimeters, both nulli and multi should have similar curves, and after 6 centimeters, multi is faster. And then what they said is after 6 centimeters, do not expect her to go for that 1 or 1.5 centimeters dilatation. You still wait. That's almost like Iron Donald said, do not allow the sun to rise and set on a single patient's labor for progress. But now they're saying you wait for more than 24 hours when you see the calculation of how long can you wait. So is it ideal for a patient? And now the reason of why the labor curves are totally changing is the maternal age has changed, increased. Maternal and fetal body size have made obstetrics a challenge now. Frequent interventions are being done, like induction of labor, epidurals and oxytocin, and all that has altered the natural labor curves. American College says 6 centimeters is the active phase. and 3 hours for the second stage in primipara and 2 hours for multi. And as Manonmani said, if you give an epidural, you add 1 more hour. So that's almost like 4 hours in second stage for a primipara. And what is the difference between the American College and Royal College? Royal College still considers active labor as 4 centimeters. WHO has moved to 5 centimeters. Progress is not 1 centimeter per hour as O'Driscoll said. Now it is 0.5 centimeter per hour. So you can wait for 1 centimeter for 2 hours. So this patient was ideally actually dilating. She is not prolonged at all. Arrest in first stage is no progress after you give oxytocin and she's got adequate contractions for 4 hours. And suppose even if you give oxytocin, it's an inadequate contraction, you can wait for 6 hours. RCOG still considers 4 hours of non-progress with oxytocin, 4 hours for an epidural for a primary in American College, and 2 hours for a multipara. And you add 1 hour if you're given an epidural. RCOG says within 3 hours in primary and 2 hours for a multi. So what I would say is please individualize your patient. I hope I'm right. Manonmani, yes, yes. Manonmani, yes.
1.5 centimeter and 1 centimeter per hour. This we should have intervened earlier. But as per the latest guidelines, it is normal progress only. If we have been having 4 centimeter active labor and we go per 1.5 centimeters per hour, then this would have been crossed the action line. So would have been
it is not 1.5 centimeters according to them. It's 0.5.
No, that's what I'm saying. That is what we have been practicing earlier. But now the guidelines has changed to 0.5 centimeters per hour. This particular patient has been there progressing as per the recent guideline. There is no progress. So delivery is perfectly normally progressing with a normal CTG. So that's what the recent guideline. Then you have to be prepared to meet this sort of consequences.
Yes,
also.
yes. You have to meet it. And you can't quote your guidelines to the patient who's not willing to listen to you. She will just say, after so much of pain and I lost the baby. And she will talk to you as if you have put a knife into her and you killed her at that point. That's the way they talk. So because there's paucity of time, I'll just go on to the last case. I'll tell you, this is totally different. This patient, 29 years old, married since 3 years. First was a spontaneous abortion. She was admitted and she was overdue by a week. So we induced her at 1 p.m. because she considered that as the auspicious time for induction. So nowadays, delivery time also, the astrology was taking over for the delivery time. Now for induction also, they are putting an auspicious time. So 1 o'clock in the afternoon, induction started. We used prostaglandin gel. Cervix was 50% effaced and posterior os was closed. Labor pain started at 3 p.m. itself. The CTG was quite reactive. 5 p.m., 2 centimeters dilated. Membranes present, vertex was at 0 station. 9 p.m., 5 centimeters. From 2, she has gone up to 5. Contractions were up to 35 seconds. At that time, this was like 10 years back. So we said it was slow progress. We did an ARM, clear fluid was there. Then we augmented labor because it was 30 to 35 seconds. Continuous fetal monitoring. So she had mild variable deceleration. So it subsided with the left lateral positioning of the mother. 11 p.m., occasional mild variable decelerations were there. Now it is 7 centimeters dilated. Vertex was a 0 station. There was a caput. Husband was informed regarding progress because he was asking like 1 o'clock, you have put the gel. We thought she would deliver by that auspicious time of 11 o'clock in the night. So he was quite angry and he wanted to know whether she will ever deliver normally, vaginally. She was informed regarding the second stage problems because this was a little slow progress. And he wanted a cesarean. Anesthetist was informed, oxytocin drip was stopped. The girl's mother refused a cesarean and she wanted a trial again. After consent for everything was obtained, oxytocin was restarted at 12:30 a.m. She went into active labor, delivered with outlet forceps at 4 a.m. in the morning. Cord was around the neck, 3.5 kg baby, male baby. Abgar at birth was 8/10. She had an arrest at 7 centimeters. That was very obvious. And she delivered after 5 hours from 7 centimeters. Active labor was for 13 hours. There was no neonatal problems at all. What should I tell you now? This is not a difficult delivery.
Yes, definitely. Waiting after the middle of the night, sitting with the patient. and calling anesthetist.
You're very
and calling
lucky
a-
that you're in a medical college that you don't need to meet these patients again and again. I'm telling you, in a private setting, it's become a nightmare. Just now, I had a problem with a patient, and that's why I joined late. It is a nightmare to manage, not the patient, the attenders. That's what we are seeing in private practice. Dr. Hemalata, what are your thoughts on this? Dr. Aparna?
Ma'am, see, this is all, whatever 2 cases you presented, it's all retrospective. If
Yeah.
everything turns well, then it is good. But anything can go haywire anytime in labor. So when everything is well, then we can say that we have managed it well. But suppose something goes wrong, then we have to analyze each and every step, and it is an individual case every time. You can't go by the them guidelines that this you are supposed to do this.
Yeah, that is a summary of this panel. Individualize your patient.
Yeah,
Do
here
not
the
go by
problem-
guidelines.
Yeah, here the
They are
problem-
useless when you're sitting in the labor room, trying to talk to a patient and a attender. And what I'm saying is, people are talking about reducing cesarean section rates. And we are talking about should have actually intervened earlier. Means the only intervention we have other than oxytocin and probably forceps when the baby is at the outlet is cesarean section. And how do you reduce the cesarean section rates when you have problems like this?
Sorry to interrupt. Sharmila?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
I took some 10 minutes break from this thing.
Okay.
I have to attend a marriage, so I got ready. Sorry for the thing.
Yes, ma'am.
I have joined now. Yeah.
Actually, in US and all, if they follow the strict guidelines, whenever the problem goes to the court, they will adhere to the guideline and the verdict comes as per the guidelines, because all the records, it is there, they followed the guidelines all over the country. But here in our country, there is no uniform standard to follow this, so the court protects you. That is a problem with this.
Yes.
So the exact guidelines we have to have, and everybody should follow the guideline. There it is completely followed. Here, each and every, it is according to the patient, we change over, but then these full guidelines all over the country, it is not there. As in RCOG, ACOG, everybody is following strictly the guidelines, not practiced here. That is a problem with us.
See,
So
we are saying,
somebody-
we are saying that the guidelines are followed and all that. No, let me give an example. My own co-sister, she was in the, she's in the United States. So she had a first pregnancy and the delivery there. Then they didn't even diagnose that she was breech presentation until she went into labor. This was in America. And second time, she again had a breech. And after leaking, they delivered her with an emergency cesarean. So the guidelines, what they talk and what they follow is quite different when you talk to your patients. And I've had a patient who had a very prolonged labor, and then I did a cesarean and she went for the second delivery to United States, and they wanted to give her a trial of labor. I said, it's impossible for you because I waited on you for such a long time and you have some form of CPD, and that's why the second stage was like so difficult. But they said, no, India will do all that. We will give you a trial. And she had an emergency cesarean again. So what they do and what they follow is quite different. But what I would like actually give as a suggestion is, I think as Manon Mani said, we should bring out a guidelines. It's time we give what happens in India. See, they talk about enema. Patient is full. There they have little food, and their food is, I think, quite digestible. Our patients eat biryani and come.
Yeah.
And labor room, when the bowel is full and she pushes out entire and the baby gets soiled, we cut a very sorry figure there.
I think by the time Charmila you discuss, should I start sharing?
Yeah, just stop. Yeah. Thank you so much.
Thank you, dear.
I would like the final thoughts by Anita, because I didn't give her much. Yeah.
You're talking about individual cases in private hospitals, ma'am.
Yes.
But where we come to the government setup, we have so many cases in labor seen by so many people. So we need to have a guidelines where we can follow the progress of labor. Many times we see cases being delivered in PHCs. They should have a referral policy when they should refer to an institution where cesarean can be decided upon, or to help out in second stage. So we need to follow the guidelines in government setup.
See,
At least in the-
Anita, what I'm saying is, when we read from Mudaliar, it was watchful expectancy and
Careful.
that is, you observe labor,
Masterly inactivity.
masterly inactivity and watchful
Watchful
expectancy.
expectancy.
I
That
think
was
that is what is working in PHCs. We are trying to intervene faster. So
Yes.
what you do is you allow her to tell her you do whatever you want until the head comes on the perineum. Then I will touch you. In COVID times, we delivered more normally compared to now because we did not touch the patient. What
Shall
I'm
I
saying is,
add something? Are
yes,
they
ma'am.
doing
the discussion
pelvic
will go
assessment?
on. I'm so
Pelvic
sorry to disturb
assessment?
you all.
Pelvic assessment, madam, you think it's useful?
Yes, definitely, because sometimes it gets engaged, but when we do pelvic, there is outlet contraction. Pubic symphysis will be in an acute angle.
Yes,
So that
and
time
then
it will get arrested at that place. So maybe it is engaged and no, there is no CPD apparently. But the pelvic thing, the pelvic brim, it's a android pelvis, then it will be like this. So that time, even with the instrumental delivery, it will be difficult. So the time old method of, we were trained like that, Bishop scoring and pelvic assessment. That helped us a lot. I think so.
I think.
And did you go for a cesarean at once when you saw a pelvis like that?
No, because everything we have to assess, no, the size of the baby. Sometimes it gets, maybe we will not try instrumental delivery, but many times we have seen the symphysis pubis has come, it has separated in the postpartum period, but it gets when with we do this pelvic strapping and all, she get normalized, no problem.
But
So
the
I think
scenario, yes, ma'am.
yeah, 35 years of my service.
I think we will have one more session for experience sharing. Thank you so much, and welcome, my dear panelists, once again, Madam Dr. Manonmani, Dr. Chandra, Dr. Swati Rathod, Dr. Rugalakshmi, I hope she has joined, and Dr. Anita. So we and Charmila had decided to split our panel discussion, that she will cover up the difficult labor with cephalic presentations. And yes, here, as all of you agree, that second stage is the most unpredictable one, though we do have some complications during first stage as well. So it is, if it was only as simple as this, they show in the movies, just 3 push and the baby is out, but it is not so. Childbirth is a sentinel event in the life of a woman and her family as well. It is intensely emotional and physical as well. Our aim of the labor should be a healthy baby from a healthy mother. It should be an emotionally fulfilling experience and not a traumatic one, as we have been talking about the respectful maternity care nowadays. Dr. Mitra has very well focused on this, power, passenger, and the passage. But yes, there are many more factors, as I said, the patient and her tolerance, the demography changing and the tolerance as well, the obstetrician's forbearance, so many factors for her, and of course the interference by other people. So without much ado, we go with this first case, and Dr. Manonmani, we would start from you. And then, of course, Dr. Chandra will take over. So we have this second gravida, para 1, with the previous normal vaginal delivery, 36 weeks pregnancy. She came to you with strong labor pains. Her vitals are good. When you examine, you find the fetal heart is absolutely good. And because she's bearing down, you just do her internal examination hurriedly. Cervix fully dilated, fully effaced, and breech presentation at station 1. Pelvis sounds adequate. How do you go ahead with the management of this patient? Rather, how would you go for the vaginal breech delivery? You can start, Dr. Manonmani.
Yes, already booked a case, so we'll be knowing there is no anomalies. She had a previous normal.
Madam, we have not mentioned that she is a booked case. She comes to you as emergency.
So probably with all the latest, all the patients coming for booking and all the checkups and ultrasound available at many of the places. So it is.
We will go to it later on, Dr. Manonmani. This is a patient you have, bearing down the bridge. You have to take a decision. How would you?
She is for normal. She is for assisted breech delivery.
Yes, tell me.
She is for assisted breech delivery because she is second gravida with the previous normal delivery and cervix fully dilated, and breech at +1 station, I'll
Yeah.
wait only for a progress and for the assisted vaginal delivery.
Yes, so
Surely.
she has
There is
come
no
to you in such a stage that you have no option but to deliver her vaginally. So you assess everything, but keep everything ready if at all some interventions are required. And for that, of course, an anesthetist, a neonatologist, and of course, a person who is skilled in the vaginal breech delivery. If you are not the skilled person, then of course you have to decide and see that the fetal status is good. So as you said, maybe it may be just a spontaneous vaginal, but before you think, the baby just come to your hand and you have to just, without assisting anything, you may just deliver the baby. This can happen as a surprise. But as you rightly said, assisted breech delivery. Now, suppose you start doing this breech delivery and the breech has come to you up to umbilicus. How would you go ahead with the delivery? Suppose if she has, extended legs. Extended legs, how would you assist? So now we go ahead with the delivery first, and then we talk retrospectively how we could have avoided this.
Yeah, if it is going to be extended breech,
Madam Chandra, you can take up this.
Extended breech is the, as if it is like a phallic presentation, because everything is extended. So the rotation, everything will happen and we have to wait for it. Then anyway, we can expect some delivery difficulty in delivering the head. So we can prophylactically, we can give episiotomy. Then we will wait till when it comes up to the umbilicus, we cover it with a sterile towel to avoid any extraneous stimulus. Then you wait up to the delivery of the shoulder. Then it slowly turns like a normal delivery. It turns and you help the shoulders holding the neck of the child. Then you put the hand on this upper thing and slowly deliver the head. That's all.
Madam, I just ask you, if the legs are extended, they're not reaching, then how
can do a
suppose they are
Pinard
difficult
maneuver.
to come down? Yes.
Yeah, you
We can do a Pinard maneuver.
popliteal fossa, then
Yes,
flex.
Dr. Anita, you want to add something?
Yes, ma'am. Same madam is telling Pinard's maneuver, where we can push posteriorly in the popliteal fossa, flex the leg and take it out. After the leg is delivered, then we have to maintain the back of the fetus is facing us, so that the head is
Anteriorly, it has to
anteriorly
be
facing the delivery person who's conducting the delivery.
Yeah.
We cover the baby, as madam previously said, so that there is no external stimuli.
Yes.
And keep the cord on the side so that there is no cord compression by the head.
Yes. The most
And then,
important
after
here is
the-
not to give any traction. Not to give any traction. Just let the baby
which will
come down with its own weight. Yes. Once the scapula
may get extended.
Yes. Then how do you go ahead with the delivery of the arms, suppose? If the arms are also extended, then how do you go ahead with the delivery of the arms?
It is the Lausitz maneuver. Then you first deliver the posterior arm. Then slowly rotate it. Then the anterior arm will come, shoulder will communicate the symphysis.
Lower level. Yes. So that is what, few of the steps where you face the difficulties. It's not always that the legs are extended. That doesn't mean that they come on their own, they descend. Sometimes you may need the Pinard's maneuver, as you have rightly pointed out, that you follow the buttocks and go along the thighs and just give a gentle tap to the popliteal fossa, so that the knee bends and you just catch hold of the ankle and let the lower limb come down, and then you hold the baby straight, back facing anteriorly. Do not give any traction. Let the baby hang by its own weight, and then once the scapulae are visible, then you can slide or splint along the humerus and just pull down the upper limbs as well. If not so, you can just rotate the trunk and deliver the shoulder, and rotate the baby on the opposite side. Let the opposite shoulder come at a lower level, and then you deliver. Now for the after coming heads, what are all the techniques and how do you go ahead with? Suppose if the after coming head is taking time, then how do you do the maneuvers? What maneuvers?
we always maintain the flexion of the head with suprapubic pressure, ma'am. Then you allow the baby to hang down, and you can do a burn Marshall technique where you catch hold of the foot of the baby and make an arc over the abdomen.
Yes,
or you can
mother's
flex
abdomen.
the baby's head by Mauritius Milliwi technique, where we keep our fingers over the malar eminence and do a flexion, and over the occiput also you do it along with the suprapubic pressure, and then we can deliver.
Yeah. So
And
with the
we can
left
apply
hand,
Piper's
you,
forceps.
yes, left hand you use 3 fingers. You put 2 on both the malar prominences, yes, and then with the right hand you push the with the middle finger you push the occiput forward to maintain the flexion, and with the other 2 you can just give a little shoulder traction. Yes, so that is Mauritius Milliwi technique, and as Dr. Mitra has also shown the forceps for after coming head. This is what just the figures, as everybody is talking about, people are not, familiar with these techniques. They are not getting to see also. So just to remind you the theoretical, the book pictures at least to see whether these are the procedures and this is how the baby is being delivered. So this is what the Mauritius Milliwi, what we were talking about. We have already described it, and this is the forceps, the Piper's forceps being applied. As we have seen that in the video also, the baby is to be wrapped along with both the arms inside, and then ask the assistant to hold it up, and then you apply the forceps as you applied for the cephalic presentation. So that is all about the breech presentation or the vaginal breech delivery. So we can have either a spontaneous vaginal breech delivery. You may have sometimes to go for the breech extraction, and that usually we do it for cesarean section. But yes, assisted vaginal breech delivery, that is the most common method of breech vaginal delivery. So now we go to Dr. Anita. We have this case who is a 34-year-old second gravida. She's having gestational diabetes. She comes to you at 37 weeks. And when you examine, you find that, yes, her abdomen, uterus is 36 week size, cephalic presentation, head is almost 3/5 palpable. Fetal heart is good, and the dilatation is 2 centimeter. The labor progresses normally, and after 6 hours, she is now fully dilated, fully effaced. Vertex is at perineum. So the progress is good, satisfactory. After 20 minutes full dilatation, the head is delivered, but the shoulders are stuck. So like this, what is the diagnosis? How do you go ahead with the management?
Yes, ma'am. First of all, in any case of GDM, we should assess the expected fetal weight, and we should anticipate shoulder dystocia, and we should be ready for it. Yeah. If needed, we should decide for cesarean.
What do you think? And what is the cutoff limit for to go for cesarean section?
More than 3.5 kg. Depends upon the patient's pelvic assessment and expected fetal weight.
Yes, yes.
Yes, madam. Now the problem is the shoulder has been struck between the anterior-posterior diameter.
So anterior shoulder with the management.
So the anterior shoulder is above and the posterior shoulder is below. Either we have a helper maneuver, we should call for help. And first thing we have to do is make Roberts, where we flex the thigh and we try to increase the diameter so that the bisacromial diameter comes out of the AP diameter of the pelvis. Otherwise, we have to deliver the posterior shoulder first. Where we have a more space posteriorly, we can deliver the posterior shoulder first. Or we can rotate the shoulder so that the anterior shoulder gets dislodged. And another thing we have to do is flex the shoulder so that the bisacromial diameter gets reduced.
Okay. Yeah, perfect. Only thing is, the moment you diagnose shoulder dystocia, it is a dire emergency, and you have to really call for help. Not only your staff and your assistant, but also the neonatologist and anesthetist. A generous episiotomy should be given. Only 2 things not to be done: no unnecessary traction if it is not coming, and no pull or no push as well.
Push
So
by
no
the mother.
fundal pressure and no push and pull technique here. That is only to be remembered. Then of course, you have to, if it is really coming out with your traction, then it is not a genuine shoulder dystocia. You can very well deliver the baby. But once it is stuck, you have to go for various maneuvers, as you have rightly described. The macroburst maneuver, of course, the hyperflexion of the legs on the hips, on the abdomen, that is the most important. And you can see very correctly the assistant is giving a push, suprapubic pressure on the shoulder, which is actually stuck. And this straightens the pelvis and increases the diameter both. So preferably it should be a combined procedure. The hyperflexion of the hips on abdomen, the suprapubic pressure. So both the things, they act synergistically and can help in delivering the baby. Then of course, the second one you said, the Woods corkscrew method. So how do you describe that? The shoulder, which
the baby
is, yes.
The shoulder, the anterior shoulder gets
the
struck. So we rotate it so that the anterior shoulder comes to a lower position than the posterior shoulder, and it comes out.
Perfect. The shoulder which is stuck at, that is at a higher level. So you have to rotate it almost through 180 degrees, you know, like this. So it has to be a half circle, then only it helps. The posterior one comes anteriorly and then it gets delivered. So that is what the corkscrew, and then you have the reverse corkscrew, which is almost a 3/4 of a circle. So that is how you have to take it in a rotation and deliver the baby. Only thing what we have to remember, no excessive force or traction anytime delivering them. So the algorithm of management of the shoulder dystocia is, the moment you see that you feel that it is shoulder dystocia, you have to call for help. All the team, what we have said, and we have to place the woman in the hyperflex position, give the macropers position, and then of course the assistant should be good enough, trained enough to give the suprapubic pressure to push the shoulder down. If that is, and then the various maneuvers as we have discussed, then if that works, that is good enough. But the attempt of the last resort, of course, the symphysiotomy may have to be done. Sometimes, the deliberate breaking of the clavicles, fracturing of the clavicles may occur. But I just hope that we need to be really cautious and hope that we do not land up into this procedures nowadays. So
even changing the position of the patient to all fours may increase the output diameter and the conjugate diameter, and also the gravity will aid
the knee chest position.
Gaskin's maneuver.
Yes, the knee chest position. Yes, you're right. So shoulder dystocia has to be managed very energetically. You have to be really vigilant on, and you have to be really very precise on the techniques what you have been using, and just to avoid the unnecessary fundal pressure and the traction. So that these are the only take-home messages from this.
Madam, one point, remember,
yes, please.
The suprapubic pressure is, we have to give the pressure on the side where the occiput is. So that is the shoulder, from the back of the shoulder, that is on the side of the occiput. The assistant standing on the side of the occiput should give the suprapubic pressure.
Yes.
So that the shoulder gets impacted from the
correct. That is what
if they give it an opposite. So the point, remember, is a person standing on the side of the baby's occiput. They should give the pressure onto the opposite side, so that the shoulder is released from the
very correctly. Yeah. So this is a picture showing the same. This is the occiput of the baby, and the nurse assistant standing on this side, and the same shoulder is being pushed.
Then better to have the drill with the persons who are there in the labor ward with us, so that at the time of shoulder dystocia, nobody gets panicky. So on and off, we should have the drill for the shoulder dystocia.
Yes, very well said. That is in fact the message for all the obstetric emergencies, that we keep continuously going for the mock drills and the continuous training of the staff as well. So thank you. And now we come to the third and the last case. We have this 37-year-old second gravida, previous seizure, and she comes to you when you the previous seizure was for fetal distress. She presented to you with labor pains, and when you examine her, you find that there are adequate contractions, 2 to 3 every 10 minutes, lasting for 30 to 40 seconds. There is no scar tenderness as such, when you examine her internally, cervix fully effaced 6 centimeters, vertex is at station 0. At full dilatation, there is severe bradycardia, and there is little bleeding, which you feel that it is more than average, which happens during second stage maybe. So when you catheterize, you find there is hematuria, blood tinged urine. So what is your diagnosis? And for this case, when the vertex is at +1, how would you go ahead with the management?
This is clear-cut case of rupture
Scar
uterus.
digital. Scar digital.
Severe bradycardia and +1 blood insurance. It's better to open up and proceed with the.
Yes, do we
Rather
have
than with
Dr.
the +1
Aparna here?
station, we cannot go for.
Do we have Dr. Aparna here? Dr. Swati?
Yeah, it says case of scar dehiscence, a clear case.
We
so
can say
there is-
uterine rupture. We do not know whether
Yeah.
it's a dehiscence or a rupture.
Okay, so it's a rupture only, and definitely we need to open her up. So just immediately do the surgery to save the baby or the mother.
Okay, so here previous seizure, query uterine rupture, station +1. She's progressing well, but there is a sudden severe bradycardia. So should we go for, should we wait for the cesarean section, or should we assist the delivery?
No,
Just
it
all
should
of
be
your
the
opinion.
cesarean.
All of
It
your
should be the
opinion.
cesarean only. It's an emergency cesarean immediately.
Yes, Dr. Swati?
Yeah, it should be only the emergency cesarean section.
Perfect.
Or the laparotomy. Baby might
Yes,
be in
ma'am,
the
laparotomy.
abdominal cavity.
Yes, so an urgent laparotomy as fast as possible, and that's the reason I mentioned general anesthesia maybe, and you have to really be very fast for this. Now, for this patient, this is just a theoretical aspect. Who are all the patients who are prone for this? Especially a rupture of uterus during pregnancy itself. So that I have mentioned the classical cesarean section and myomectomy. And of course, during labor, as you can see the previous scar on uterus and grand multiparity, and whatever the drugs we have been using, the misoprostol, that is why the message is here. And for nulliparous women, birth should be expected to take place within. This is, I think, these are the certain guidelines I have just tried to add here. But as we have been talking about the case, as you have said, there is no second opinion. It has to be an urgent laparotomy, I would say emergency cesarean section, but exploration of everything and see whether where and how the rent is, whether it is repairable or no, whether it is the patient is bleeding profusely. And then, of course, considering the parity of the desire for childbearing, the type of rent and the extension into the parametria, whether there is hematoma or so. So accordingly, we have to go for a conservative procedure, that is the repair, or maybe you have to go for an obstetric hysterectomy. So accordingly, we can take the decision here. So principles to avoid litigations, as we have been talking about all the time about litigations. Again, the last slide is for that. Good communication with the patient and relatives, explaining them all the from time to time. You have to be really transparent with the patient and relatives. You have to maintain the documentation of whatever communication you are doing, and of course whatever treatment you are doing for the patient. Good consent, it's written here, but I would say informed written consent for every procedure, right from the whatever medication you're giving for induction. I heard even Jaya ma'am saying that you may even need the consent for nowadays for episiotomy also. So accurate representation, and you have to be really have empathy with the patient. That is how you can be successful. Of course, intelligent anticipation. You have to anticipate things timely. You have to be really supervise them, being very vigilant in your monitoring. Prompt detection and effective institution of the therapy can prevent the disastrous consequences as well as the litigations, I would say. So let us place to make birthing safe and respectful. And with this, I just finish my short panel discussion. I hope because of the time constraint, I think we have to really wind up it. And I just check whether Noza sir has joined. If not, just in a moment I will call.
He is there, madam. He is there, madam. He has joined, madam.
Can invite him.
Thank you, Sneha. We are Madam Kamila.
We had a wonderful panel discussion by the moderator Sneha ma'am and Charmila ma'am. It was a wonderful panelist. Thank you for the extensive explanation by Manonmani ma'am, Chandra Purnasamy madam, Anita ma'am, Swati ma'am. Thank you. We had a wonderful discussion, madam. Now we will go for the.
Thank you, Shobana.
Thank you. And I wish Dr. Sneha, I wish you
Good evening.
success in their election, and
I-
Dr. Umayal.
Actually, because hurriedly I could not make an appeal, but I just request all of you to support me for my candidature as Vice President Foxy. And thank you so much. I'll be in touch with you all. Thank you.
Thank you, ma'am.
A very good evening, Dr. Noza sir. You can go ahead with the introduction.
I welcome the chairperson for the second talk, Dr. Hemlata ma'am, who is now the member of Foxy, IMS and ISAR, Secretary of Namakkal Society, and Dr. Shraddha Paritkar, who is Honorable Secretary of Aurangabad. I welcome the chairperson. I now request Dr. Hemlata ma'am to introduce Dr. Noza Sariyar sir.
About the estrogen thing.
Yeah. Good evening, sir. Welcome. Noza sir, good evening.
Very good evening, sir.
Good evening.
Dr. Nazar, I don't want to say much about you. You are a very familiar person, and I'll just add upon the credits you have holded so far. You are the past Secretary General of the Foxy and past President of Mumbai Obstetric Gynec Society, and you have chaired so many FIGO conferences and delivered so many orations and presentations, and you have got the Young Gynecologist Award, and so many other credits added, much not needed to say about you, sir. We are very happy to be here, and we are eagerly waiting for your speech, sir. Last time we missed it last week, and we don't want to miss again, and hope all the speakers are eagerly waiting for your talk, sir. Over to you, sir.
Hi, good evening. Could I share my screen, please?
Sir, please.
Ready?
Bhavna, can you help sir whether you have made him co-host?
I have made him the co-host, ma'am.
Yes. Okay.
Am I audible? Is my screen seen?
Yes,
sir,
sir.
you're audible.
But your screen is not seen, sir. Please share your screen, sir.
Okay, I have done a screen share. I'll just have to really help me.
Bhavna, can you help me?
Ma'am, screen share is not visible actually.
I've got it. Right?
Yes, sir.
Yes,
Yes, now it is.
Okay. So it's really a privilege to be a part of this program. I'm sorry I had a busy day and whole thing was running late. So thank you so much, Sneha, for accommodating me and not dropping me completely from the list. And it's such an honor to also see Dr. PK there, who is such a friend. So I'm going today. There was a lecture earlier on instrumental deliveries, and I'm hoping that what I'm going to say today is going to complement that. And I'd like to first start off by quoting Barbara Rothman, who said, "Birth is not about making babies. It's about making mothers, strong, competent, capable mothers who trust themselves and know their inner strength." Now, if you look at that first picture from 7000 BC, historically, the oldest figurines in human history were all of pregnant women. They were the mother goddess. This is from 7000 BC in Mesopotamia. In the Middle Ages, in the Renaissance, we suddenly had more definition of what was happening inside women. And you can see quite a clear picture of a fetus. Of course, they've shown the uterus to be opened as almost kind of a flower with labeling. And then there was that absolutely iconic Vanity Fair cover of Demi Moore, who finally stepped out, and pregnancy was something to be flaunted and be proud of and not be embarrassed about and not hidden. Today, I talk to you about optimizing vaginal birth in a clinical practice, and I will speak to you some evidence, some of my personal experience. And for me, this is the essence of obstetric and obstetric care. Our branch obstetrics is derived from the Latin word obster, and obster comes from to stand beside. And somewhere along the way, maybe we obstetricians have forgotten that. And if we are going to give the woman in the center of our lives, our patient we are looking after, it is something we need to probably go back to. Let's face it, the world has two extremes. Too few cesarean sections in some part of the world, like Africa, and too many cesarean sections. And here they've shown Australia, China, Brazil, and the United States of America as having a very high cesarean section rate. If you see the overall rate in India, we are not badly off. As a country, we are 17%. It's gone up from 3% in early 90s to 17% now. It's quite a dramatic increase. And you know, I hear about the WHO rate of 15%. Well, that's not true at all. They'd come up with that number saying that beyond 15%, you don't seem to have that kind of a change in maternal and perinatal outcomes in terms of mortality and serious morbidity. In fact, they said you should have a rate that is appropriate. Now, what concerns me is in a country like ours, you've got so much variation between states, varying from 57.7% in Telangana to 8.6% in Madhya Pradesh. Maharashtra is not badly off overall, 20%. But again, in Maharashtra, I believe that we are somewhere between too few in the public sector, and maybe we could do better in the private sector. Kerala usually serves as a role model for us, and it's pretty much somewhere around 30, 35, 38%. And interestingly, public and private are almost the same. We are being judged. According to the WHO, cesarean section use is now accounting for 1 in 5 childbirths. They say the number is going to increase, and by 2030, it's going to be 1/3 of childbirths. Considering it's 140 million births each year, cesarean sections have become the most frequently performed surgery. And on the left, I've written, look what people are writing about us. And most of it may not be justified, but we have to be sensitive to what people are saying. Let's not get defensive. Let us admit that we do have an issue and a problem, and go back to seeing what can we do to give women what they want. And I believe in many cases, it is a vaginal birth. This was a study which said that women were asked to choose a type of delivery. A majority of women favored a natural childbirth. The physiology, the birth experience, the personal assistance. I know today we do have some cesarean sections on demand, and I completely respect that. We had discussions in Foxy when we came up with a cesarean section guidance. And I'm proud to say that we actually put C-section on demand as an indication. Because if we are to believe in a right to choose, that also is a right, so long as it follows scientific evidence, which basically means no doing them too early, no doing them at 35, 36, 37 weeks. As long as the woman has been counseled honestly and adequately without putting a fear of one or the other mode of delivery. This is a checklist I use in my practice, and I basically want to say that everything is down to checklists now. And I want to highlight 2 or 3 things that we are very, very particular about. The first is a diet consultation. Every patient in my practice has to work with my dietitian. It saves them money because I don't do all kinds of supplements, only what is required to supplement a diet. It gives me better rates of lower rates of diabetes in pregnancy, better control of weight gain, and every patient has to go for an antenatal class. And my preference is always yoga. I know in India, we are Indians. This is our gift to the world, and why not use it for our patients? I'd like to first start off with talking about maternal obesity, because this is a problem we are facing increasingly, at least in the private sector. We are seeing a lot of overweight women coming to us. We make sure that every woman has a BMI calculated at first visit. It takes you exactly 10 seconds to do it with a very simple formula, which you can do online. Every woman has a routine diet consultation, and if they are overweight, there is a strategy where she's immediately put for restricted weight gain, which is aerobic exercise, metformin, and aspirin. I present to you 43 cases. This was from last year. Of these cases, the mean BMI was 34. That's obese. Okay, 25 to 30 is overweight, more than 30 is obese. The mean early weight at first visit was 88.6%. At delivery, the mean weight was 91%. We delivered these 43 women with an average weight gain of 2.8 kilos. This is a study which said that no matter what you tell women, even if you tell all of them to exercise, and that's what all of us do, only 40% exercise. And here you have to motivate them. There is this review of yoga during pregnancy in the American Journal of Perinatology, where they looked at 5 observational and 3 RCTs. Less preterm labor, less IUGR, less sleep disturbances, less lower back pain and discomfort, less stress, and an improved quality of life. You can see why we can do such good for our patients by recommending yoga. What about a birth plan? This is something that modern contemporary women who go online to websites come to you with, and they will say, "Doc, can I have some kind of a birth plan?" When you have a birth plan, you basically are encouraging the woman to clarify her expectations. We feel threatened by birth plans because we say, how can a woman tell us what to do? And I sit with the birth plan, and very often they will come with a printout from some website, and I will tell them what I can do and what I can't. And much of them, of what they ask for, we can do. It has been shown that a woman who has a birth plan is less likely to undergo a cesarean, more likely to have first and second degree perineal tears, and more likely to have epidural analgesia. I'll come to the perineal tears later. I believe we should encourage our patients to read so we can control what they read. And according to me, one of the best books to recommend to your patients is Dr. Geeta Arjun's book on Passport to Healthy Pregnancy. It's available online, and it's written by an Indian obstetrician for an Indian patient. But I maintain a library and I keep adding to it, so I know what my patients are reading. And I believe me, sometimes just leafing through these books gives you ways of talking to patients and guiding them and making our practice better. We have to be more prepared for patients to use the internet. Internet use is like never before, and it has been shown that women access internet for health reasons more than men. And women will read about hospital water birth, home births, and we've got to be prepared with responses. Do not feel threatened by Dr. Google. I welcome it. I tell them, because they're going to go through it any which way, but then you have to have humor and deal with it. And I always have Okay, so coming to what Warren Buffett has said, chains of habit are too light to be felt until they are too heavy to be broken. We today have a list of criteria for a mother-friendly birthing facility. Most of these are common sense. Opportunity to eat, drink, walk, stand, and move during the first phase. We allow a patient to have normal diet early in labor, but once she's in active labor, clear liquids, not pulpy juices, and allow that to happen throughout. Position of choice, I'll discuss this a little later, not always practical. Privacy, extremely important. You know that even in private hospitals, sometimes we are insensitive. I often see nurses coming in a very, very fancy hospital and whipping off the sheet from the patient. And of course, comfort of a person of the choice. I will talk to you about the non-application of things which are literally harmful nowadays. We are challenging traditional routines. These are the recommendations graded A, B, C, and D. Routine enema and perineal shaving is now a D, which is recommended against. I believe middle ground. I offer an enema to my patient. If she says, you know, doc, I'm fine, I don't think I need to, that's all right. Otherwise, they can. Perineal shaving, I ask them to deal with their hair before they come from home. Otherwise, use a clipper. Perineal shaving has been found to be harmful. Oral liquids not recommended against. Admission test, I do. Not recommended against, but not a routine provision. And early ARM, definitely a no. What about induction of labor? Now, this is always where the controversy comes out. But there was a very interesting paper in the New England Journal of Medicine in 2018, where they showed labor induction in 3,000 versus expectant management in 3,000 women in nulliparas. And they found that in the induction group, you had less perinatal complications than in the expectant group. I mean, this is a no-brainer because the expectant group became post-dated and we know about the risks of meconium and a hypermature placenta. As far as secondary outcome is concerned, they also showed that the induction group had fewer cesareans, 18%, as compared to the expectant group, because the expectant group often when post-dated had larger babies, had fetal distress, and that's why it was higher. So if you were to do a judicious and timely induction, this should usually be done in the 39th week, preferably for a medical indication, but otherwise if the woman has a favorable Bishop's score. If you're determined to induce, trust me, you will succeed. And this is the kind of practice that we follow. I usually do a membrane sweep if the cervix is favorable at 38 weeks. It is uncomfortable, it is painful, and she may sometimes bleed, warn her. If the cervix is completely non-inducible, she has a poor Bishop's score, and I still want to do an induction, I use mifepristone. Yes, mifepristone 200 milligrams in 36 to 48 hours before. There is a Cochrane systemic review in 2009 on the mifepristone for induction of labor. I then use a PGE2 gel. You could use the pessary. I use it 6 hourly. I go up to 3 doses. Recommended is 2. Reduces cesarean sections by 10%. And after that, if she's still not in labor, I might use sublingual meso and then finally give her the epidural. She's 4 centimeters or 5 centimeters, do an ARM, and she will usually deliver within the next 4 hours. Questioning more traditional routines. Perineal massage is class A or B. I'm going to talk about it soon. Perineal pack during labor, class A. Fundal pressure, absolutely a no, but I must confess, all of us will use it, but use it judiciously, use it gently. Routine episiotomy now is recommended against. Yes, recommended against, and a delayed cord clamping is recommended for. I use partograms. We are now shifting to the new WHO partogram, but I traditionally use this partogram, which we used to use at Wadia Hospital. I really like that. And we have a normogram, and you can see here, I've shown you 2 patients here where they were fully dilated for well over 2 hours. The new recommendation is nulliparous, more than 2 hours, but more than 3 if she has an epidural. Multiparous, more than 1 hour, but more than 2 hours if she has an epidural. And if you see, those decelerations which you're seeing in the graph on the right, they are early decelerations. They are not any cause for panic, because these are just telling you that you have head compression and not fetal distress. Why the cup of coffee? The cup of coffee is my secret weapon. When an obstetrician is in the labor room, when she's fully dilated, we are tempted to interfere. Trust me, if you leave the room, go and wait somewhere else, have your coffee, work on your meals, do whatever you do, and you come back, the station will have come down, the head will have rotated, and very often you need minimal intervention. That's the new WHO labor care guide. We should all switch to it. It's completely changed the monitoring of labor. The first part is supportive care. Just imagine companion pain relief, oral fluid posture. The second part is baby and its condition. The third part is the woman. And the finally is the labor progress. The biggest fear women have is pain. And for me, nothing can be better for pain management than an epidural. Now, I do understand that it's not feasible for a majority of women, but today a large number of women are delivering in facilities where it is an option. Epidural analgesia is found to favor both dilatation and descent, and the odds of having an operative vacuum delivery increase and there is a reduction in C-section outcomes. This study showed that epidural analgesia actually favors a normal course of labor if it's not discontinued or delayed. Now, that is a birthing chair. I saw it at a birthing unit in the US. I can't have patients delivering on that because as an obstetrician, where would I sit? So what we do is we kind of compromise by not tying up the legs in stirrups, by getting the woman to be almost in a squatting position, by raising the head end of the labor bed so gravity helps, and then going ahead with this delivery in this position where we are better able to control it. Of course, and this is also doable, particularly for people in private practice. We usually have photographs while the baby is in the delivery room, and I will never have deliveries without playing music for myself and my patients. What about husbands' participation? It was shown that a majority wanted the husbands to participate. I've had husbands in my labor rooms for the last 25 years, almost as long in the operation theater. People think they come in their way, they don't. There is a lot of favorable mental support. It's a wonderful moment to welcome the child in. Thankfully, today in private practice, the husbands are participating like never before. And I always say that my secret agenda is when a husband sees his wife giving birth, he completely changes the way he looks at her and the respect he gives her. Jawaharlal Nehru said a policy of being too cautious is the greatest risk of all. ACOG, NICE and RCOG, SOGC and RANSCOG all recommend against routine episiotomy. In 2016, I had a delivery in a private hospital. I'd given an episiotomy. I did a vacuum. It was a tight fit and I had a rectal injury. And it made me remember something my friend Geeta Arjun had told me, that if you go to a shop to buy fabric, the salesman will make a small nick with a scissor and the fabric will rip. But if there is no nick, the fabric won't tear. And I said, maybe is there something that I can do to avoid this nick in the fabric? There are 12 studies, RCTs in this Cochrane database review for selective episiotomy in unassisted vaginal birth. There was less perineal and vaginal trauma. There was less blood loss. There was no difference in infection in infants. And it showed that selective episiotomy resulted in actually a better outcome for the perineum and the vagina. We ask our patients to start doing a perineal massage at 36 weeks. And this is again a Cochrane database review of 4 trials, a large study of 2,400 women, less trauma requiring suturing when the woman did a perineal massage, less likely to need an episiotomy, no difference in instrumentation. And it's extremely well accepted by women. You could use a specialized oil, you could allow coconut oil, You could allow olive oil, and women are told, if you do it, we might avoid an episiotomy, and they will. During labor, we've always done perineal massages, but it's been shown that doing a perineal massage in the second stage using a water-soluble lubricant actually helps. And there's a lower incidence of severe perineal trauma, more intact perineum, less episiotomies, and they've also advised the use of hot packs. Here, I have got a new application for my sim speculum. I actually use the sim speculum to pull the perineum back while the woman is pushing. And then when she's finally delivering, since I'm not giving her an episiotomy, there very often is more trauma to the anterior segment. I use the sim speculum to protect the urethra and the paraurethral tissues. I must confess here that I do use a lot of vacuum now. I would very much use a forceps earlier on. And when I use the vacuum, I don't have an episiotomy. In fact, my vacuum very often helps me avoid an episiotomy. And you can see that I'm protecting the perineum. I'm flexing the head, suboccipitobregmatic diameter. Remember that. I am not in a hurry to pop that head. We are always in a hurry at this time. We pop the head, someone's giving fundal pressure, and you gently create as much space as possible. And when you bring that head out 1 millimeter at a time, you will probably be able to get away with doing minimum trauma to the perineum. I always say the difference is how you open a champagne bottle. You can either pop the cork or you can ease out the cork. And the perineum tears the most when there's that sudden push that is done by the woman or by an assistant pushing from above, or you by pulling very hard from below. 1 millimeter at a time, take your time, and just get the head out at that particular very gentle speed. There comes the head. So this is our recent data. I now deliver almost 83-84% of my patients without an episiotomy. I wouldn't have believed this if someone told me this 10 years ago. Trust me, every one of you can do it. I've heard it all. Oh, Indian women have small perineums, rigid perineums. We've measured perineums. Most of the time, it's a 1st and 2nd degree tear. Yes, you do have a 3rd degree tear, but I'm no longer afraid of perineal tears, and we do it. In fact, you have to be willing to suture a perineal tear now. We have to teach this to our juniors. I have a perineal repair kit in each labor room. If it happens, you see how you're picking up the edge of the sphincters. You suture the sphincter properly after identifying it. You then do a continuous suture for the vaginal tear. And when you've done this, this is the second, I take 2 or 3 sutures on the sphincter. You can overlap the sphincter, you can bring it together. And the RCOG has great courses for these kind of procedures. And I think it's time we should also start doing these courses for our students in our medical colleges and for maybe practitioners in Foxy. So this is where you're bringing the vagina together to the mucocutaneous junction. Try and bring everything perfectly because you want everything to heal by primary intention. A few muscle sutures after that. And at the end of it, in this case, it was a 3rd degree perineal tear, but most times it's just a 2nd degree or a 1st degree perineal tear. And that's great. I just delivered a gravita to this morning, absolutely no tear, but you have to be really patient and use the vacuum. And you go there, you come to then I do the muscle, and then the skin is done subcuticularly, and you'll have such a nice scar, you will have less pain. So that's the mucocutaneous junction. And after that, you'll do a few sutures for bringing the perineal muscles together, and then subcuticular suture there. Interestingly, ACOG, America, with all its litigation, has said many cesareans can be avoided if operative vaginal delivery is considered the option in the delivery room. This is level A evidence. I know there was a lecture on this, so I'm going to move very quickly through this. One of our most challenging things is a persistent occipito-posterior position. There's expectant management. You wait long enough, it will turn. Digital rotation, I very often just use 2 fingers, but remember to push the shoulder abdominally when you're rotating the baby. Instrumental vacuum and forceps delivery. Now, people often tell me, is there any absolute indication for the forceps? And I tell them, yes, one, face to pubis. Nothing works like a forceps delivery when it's a persistent occipito-posterior position. This is a Hayes forceps. I'm privileged to have 2 of them in 2 of my hospitals, but you could use any forceps for this. The Hayes forceps is a parallel forceps. I always bow to Dr. Subhash Nargolkar every time I'm doing these deliveries, because he's the man who did the Western India trial. He's the man who really did more for operative vaginal delivery in our country than anyone else. And he was the chair of the FOXC Food, Drugs and Medico-Surgical Equipments Committee. And so many of us followed in his footsteps by using him as the ideal committee chairman to follow. So you can see here, I can extend the blades. I can flex the shanks by the Pajot's maneuver. And when you're doing a face to pubis, the first thing that happens is your handles go upwards, because you start off by flexion and flexion and flexion till the nape of the neck comes to the perineum. This is why it is difficult, if not impossible, for a woman to deliver this position without assistance. And then you deliver the baby's head by extension. A new issue has come up, and that's the preterm fetus. We are delivering more and more babies preterm because of better NICU facilities. Vacuum deliveries are contraindicated. And here I'd like to tell you that my new acquisition at every hospital is the Piley forceps. I mean, all of us know Dr. Piley. We admire him. We love him. He's one of our best teachers and passionate obstetricians. He's done so much for Kerala that I sometimes envy we can't do in the rest of the country. Now, the Piley's forceps is a set of 2 forceps device for the preterm baby. This is what would traditionally call the cage forceps. It is a crossed forceps. I will give an episiotomy if I'm dealing with a preterm baby. This baby was somewhere between 32 and 34 weeks. And you can see again, you're controlling by initially flexing, bringing the head down. And when you've got good flexion, here you have to be very gentle, because you don't want to create any trauma to the baby or intracranial injuries or hemorrhage. And then gently deliver the baby's head by extension. Okay, you have to adopt a very, very slow pace at this time. I could have pulled this baby out many seconds or a minute ago, but don't be in a hurry, deliver by extension and that. And the Piley's forceps, the smaller forceps is the one I use for preterm C-sections. I just did one on Sunday where one baby was 770 grams and the other was 825. And trust me, lower uterine segment not formed, vascular, the baby bobbing away so small, you have to be gentle. I don't want too much fundal. This forceps gives you complete control. Of course, you also have varied options in vacuum design. I used to love the Bird's cup. I thought metal cups were the best. I now very often use the Mitivac, which is the second one from the left. Samuel Johnson has said, life offers no higher pleasures than surmounting difficulties. Shoulder dystocia is something we've all dreaded. I think every obstetrician kind of wakes up with this nightmare at some point. Have this chart in your labor room. Help, call for help, give an episiotomy, do a McRoberts maneuver. Suprapubic pressure, never fundal pressure, enter maneuvers, remove the posterior arm and the shoulder. It's something that works very well in the Gaskins maneuver. Now, this was luckily 2 videos I managed. It was kind of a shoulder dystocia. And you're delivering the head. You can see that the speculum has come out from the front. And after you've delivered the head, suddenly everything stops. And now people panic. And they start pushing from above. And suddenly someone's giving fundal pressure, which is only jamming the shoulders even more. And I suddenly realized that this baby is not coming down. The baby's face is all red. So get an assist and get the pediatrician to just suction the baby. See what the assistant is doing. Suprapubic pressure, McRoberts maneuver. And then you'll suddenly find that the shoulder just slips out under the pubic arch. And of course, sometimes I just put my hand in posteriorly and get out the posterior hand. And you can see how the baby is is being born thanks to, and documentation is important. If you document that you've done the microbursts and suprapubic pressure, and even if there's a complication, nobody can create problems for you in a court of law. And these are the other maneuvers, the gaskets. Now, this is something I do. I think many of you all know. I started doing it with the Western India trial in the early 1990s. For me, it's become a routine, using a short obstetric forceps for a C-section. And I personally feel it gives me tremendous control, small fan and steel incision, no need for the anesthetist to be give that massive fundal pressure, very gently slip one blade in. It's extremely simple. Please do it. Don't wait for a difficult case. Of course, it's fabulous when you have a floating head. It's even better when you have an anterior placenta. This is a crossed forceps, so the posterior blade goes in first. The other blade, that's the right blade, goes in above. And then you've held that baby, and then you gently flex the head, suboccipitobregmatic diameter, and you deliver the head by flexion. My purpose of showing you this is to tell you, please use instrumentation. When students see you using this at cesarean, they will have the confidence of using it at vaginal delivery. I take out the C's at the last moment. You can see how I'm not even wasting a millimeter of my incision. If I'd put my hand in, I would have had a much bigger incision, and the baby's head is delivered. Henry Ford says, whether you think you can or you can't, you're usually right. Contemporary C-sections, I had to talk a month ago, and I decided to divide it into 3 indications. Justified, breech, term breech. PK is here, term breech, trial done, whatever. Let's face it, most of us are delivering our breeches by C-section. I've delivered 2 or 3 in the last few years. One was inadvertent. The others were patients who asked for a vaginal breech delivery, and we obliged. Transverse lie, placenta previa, significant FGR, particularly if there's affection of blood flow, not otherwise. Preterm birth, for extreme preterm birth, I wouldn't do a normal delivery, and maybe 2.5% on request. Gray zone is repeat C-section. Let's face it. Twin pregnancy, most of us will, and macrosomia if the baby is really big. But debatable, elderly mothers, 35, 40, doesn't matter. They can deliver normally. Obesity, I've delivered 125 and 130 kilo women normally. ART pregnancies, definitely not an indication for C-section. And the one that I'm most ashamed of, cord round the neck. I mean, when did that become an indication for a C-section? For a cephalic presentation. Breeches, I might be a little worried about. Let's look at the value of the Robson's classification. I feel that tomorrow, if someone challenges me, I will tell him, look at my C-section rates for group 1, 2, 3, and 4. Don't look at the C-section rates for group 5 to 10. Now, I've just said this aspiration. A primee who comes in spontaneous labor should not have more than a 15% C-section rate. A multi, not more than 10%. Induction of labor, primary 30%, multi 20%. I think this is reasonable. And I request you in your hospitals to use the Robson's criteria, not only for C-sections, but to audit everything. And you will find that you will practice much better obstetrics. What about trial of labor after a C-section? Definite value. In fact, it is shown that for the mother, delivering vaginally after a C-section was safer because major surgery C-section has its risks. But you can make this safer. There is an online MFMU calculator. You can go online, feed in your patient's data, and you come up, this patient I fed in was 30 years old, 5 feet 6 inches, 60 kilos. She was not an African-American Hispanic. She had a normal delivery before once, and they told me that your predicted chance of delivery is 90%. You also have a prediction when she comes in labor. So do a VBAC score. Bishop score, history of vaginal birth, pre-pregnancy BMI, non-recurring indication, age. And then you add the points together, and on the right-hand side, you will see, for example, if your points were 20, you had a 90% success, but if your points were 10, you only had a 49% success. Elderly women over 40, this is our practice, again, quite some time ago. It's totally changed now. We've got much better numbers, but this is something that's going to come in the Indian Journal, 50 patients. And what did we have? We had a C-section rate of a normal delivery rate about 34%. Now, these were over 40, 40, 45, 47. A healthy elderly mother definitely has every chance of delivering normally if she wishes to do so. IVF pregnancy 69, well, let's face it, 1/3 of multiple pregnancies, they are out. So I only looked at Robson's group 1 to 4. Even with IVF pregnancies, considering, look at the indications below. MSL, PPROM, non-progress, macrosomia, PPIH, FGR on request, a high on request in these patients. We still had a 32% chance of a vaginal birth. Let evidence be your guide. My request to you is please download these documents. The central document is fabulous. We have our FOXY GCPRs, the good clinical practice guidelines. Keep all these on your phone, keep all these on your tab and keep reading them from time to time. Danica McKellar has said, I know we can't always know what medical surprises may happen in childbirth, but my hope is to go fully natural. Wish me luck. And I'd just like to share one very interesting thing I read in a business newspaper, but I modified it for our practice. It said business, or I'll say medical practice is just like love, building relationships, working on communication skills, and remembering the little things about patients that maybe no one does. You know, if you have the patient's paper, make an entry of a previous older children's names. Just making them feel you know something about them makes them feel so special. She said, never forget that the person in the center of your life is your patient. Thank you very much. I know it's late in the day, but thank you for staying on.
Thank you, sir. Thank you so much for excellent talk. It is an absolute privilege to listen to you after so many years. I still remember as a student in Nair and Nanavati, we used to rush to listen to you at Wadia and different places. So it was so nice to hear you from after so long. Sir.
Thank you, Shraddha.
Yes, sir. It was a real visual as well as audio treat for us, sir. And thank you so much, sir, for your excellent presentation. Thank you, sir.
Thank you, sir. That was wonderful. I mean, it was really audio as well as visual treat for all of us. And I'm sure everybody is benefited and learned a lot from your talk, sir. Any comments the chairperson wants to make? And of course, we have Dr. P.K. Shah, sir, with us. So we would also like to have your comments, sir.
Thank you, sir. It was an amazing talk. We really enjoyed your talk. It was really amazing. Sir, please continue, sir. P.K. Shah.
No, I think I told you earlier on, it's always a pleasure to listen to Nozer on any topic, whether it is MTP, whether it is delivery, whatever you ask for family planning. And I always make it a point to see to it that if I am available, then I listen to him, whether it is a conference, workshop, webinar, etc. And today was an academic treat. I think all of us are not going to have our dinner. We had enough form of academics today since 6 o'clock, and I enjoyed thoroughly. Nozer, nice to see that you covered the topic so beautifully, and you have not left any page unturned, especially when it comes to vaginal delivery. And I think it's a lesson for all of us, and even our junior colleagues, the younger generation of gynecologists, that they should come back to vaginal delivery and not resort to C-section, because that's a very shortcut of obstetrics. And I hope that our C-section rate comes down in future and our vaginal delivery rate comes up, and even new operative vaginal delivery rates come up. Thank you so much.
Thank you, PK.
Thank you, sir, for that very analytical comments. And I would just like to share with you that because this is academic platform, we are here always to look for that whatever subject we plan, it should be very practical and very useful to the delegates. And we see to it that the subject is, from the stalwarts who actually deliver it. So I'm very happy to have the authorities in the subject today, Dr. Nozer Shehryar, and of course, Dr. Mitra, and the wonderful panelists. So thank you so much, sir, for accepting our invitation and guiding us. Over to you, Dr. Shobna, for the vote of thanks.
Thank you, madam. Thank you is the best prayer that anyone could say. I say that one a lot. Thank you expresses extreme gratitude, humility, and understanding. Thank you all for the wonderful session. It is really, as PK sir told, it is an academic feast we had today. Thank you, sir, for giving us the sharing time with us for the entire session. And Revati ma'am and Nirja Batla ma'am, thank you for being as a guest of honor for throughout the session. And we thank the ICOG office bearers, Dr. Lakshmi Shrikande ma'am and Ashok Kumar sir. We also have 2 ICOG credit points for the session, and the AMOGS office bearers, Dr. Rajendra Singh Pradeshi sir, President and Secretary ma'am Sujata Dali ma'am, who joined for the occasion, and Dr. Nandita Palshetkar ma'am, Dr. Kiran Kurkoti sir, and our own Sneha Buer ma'am. And we had a wonderful talk by Mitra Saxena ma'am on instrumental vaginal delivery. Thank you for the wonderful videos, ma'am. And the panel, which was very great by Dr. Charmila ma'am and Dr. Sneha Buer ma'am. And excellent inputs from our panelists, Dr. Manonmani ma'am, Dr. Chandra Ponnusamy ma'am, Dr. Aparna Raul, Dr. Swati Rathore, and Dr. Anita Tamrechelvi ma'am. We had a wonderful session, and by the end is the feast by Dr. Noza Shariyar sir, who gave an excellent delivery on how the normal vaginal delivery is to be improved, the need of the hour. And thank you all the chairpersons, Dr. Hemalata ma'am, Dr. Shraddha Paritkar, and our own convener, Dr. Umayal Murugesan ma'am, and my co-coordinator, Dr. Anit Kumar. And I thank the technical support, Bhavna and Piyush, for the technical support you have made. And I also thank the Almighty for the wonderful session. Thank you, Sneha ma'am, for guiding us. Thank you so much, ma'am.
Thank you so much, everyone. Thank you so much.
Thank you. Just like these videos, if only we have live workshop conducted in various places, it will be much beneficial. But I don't know whether it will be legally possible to have a live workshop for deliveries.
Not possible, madam.
For the program labor, we used to have few previously, but I don't think so. We can have it.
That's what that.
Because it
Very,
is
very
an
nice,
emergency, we can't plan it unless sir says that you induce at 39 weeks and go